Dr. Deeptendra is also joining. Tanay, you can set the ball rolling, please.
Fine, fine.
And then request Dr. Pankaj Shah to give a brief introduction.
Sure, sure. So, good afternoon, everyone. I'm Dr. Tanay Shah from HCG Ahmedabad. So, on behalf of the organizing committee of Gujarat Breast Meet 2020 and HCG Cancer Hospital Ahmedabad, I welcome you all, and I sincerely hope and wish that all of you are keeping good health during this pandemic time. So, talking about GBM, it is our biennial conference in the ever explored field of breast oncology. And this is our third venture. First was in 2016, then in 2018, and now. So actually, this was planned in the month of April this year in Ahmedabad itself, but due to this current pandemic scenario, we had to unfortunately cancel it. But as we all know, that sharing of knowledge should have not any restrictions. So here we are on this virtual platform to enrich ourselves with the updates and better understanding in this vast field of breast oncology. To brief you all about the program, it will comprise of panel discussions of 4 hours a day for today and tomorrow. And during this, we will have very eminent and experienced faculties from all over country, and who will be sharing their knowledge on current updates and guidelines for the management of this very common but potentially curable problem. And we shall be able to increase the horizons of our knowledge and understanding about the disease by the end of this meeting. So just briefing you about today's topics, it will be upon genomic assay, escalation therapy in early TNBC breast cancers and de-escalation therapy in early HER2 positive breast cancers. Also, there will be discussion on loco-regional management after neoadjuvant systemic therapy in LABC and selected oligometastatic cases. And lastly, we will be discussing something about increasing role of oncoplastic breast surgery in today's scenario. So thank you once again. I welcome you all. Our first session will be comprising of two panels. We have Dr. Pankaj Shah sir with us to chair this session. To introduce him briefly, he is currently heading the medical oncology department at ZYDUS Hospital Ahmedabad. He is a professor emeritus at GCRI Ahmedabad. He is vastly experienced oncologist and a very ardent teacher as well. He is recipient of many prestigious awards like Dr. B.C. Roy Award and Padma Shri Award, to name a few. It will be an honor to have him chair a session in this conference. So without wasting much of the time, I hand over to Dr. Pankaj Shah sir, please.
Thank you, Tanay. Thank you, Mansi, and thank you, SCG team. We are living in the era of the COVID, and COVID has given many things. But to me, the most important is, without going out of Ahmedabad, every day, at least 3 days in a week, we are learning something. Breast cancer has now is the most common cancer in the women, and around 1,64,000 cases are reported every year in India, and the death is also, the mortality rate is also 27%. The issue is so common, and now the knowledge in last 1 decade, when I retired in 2010, in the 10 years, it has so much, we have gained lots of research which has come from the bench to the bedside. And I'm very happy that the selection chosen by the SCG team. GBM, when it comes to my mind only glioblastoma multiforme. And it is also a brainstorming. So let us start the first session. The chairman, the moderator for the session is Dr. D.G. Vijay, a pioneer of the breast cancer surgery, exclusive breast cancer surgery, probably in India and in Gujarat. Now over to Dr. Vijay. You introduce your panelists and start the ball rolling, and let's have excellent learning experience on the basic aspect of breast cancer, and particularly the role of genomic. Dr. Vijay. Over to Dr. Vijay.
Thank you, sir, for those kind words. And I welcome all my panelists to this panel. Bhatt, who is a consultant surgical oncologist at the HCG Cancer Center in Baroda. Dr. Chirag Desai, a well-known medical oncologist, hematologist at the Hemato-Oncology Clinics, Vedant Hospital at Ahmedabad. Dr. Amit Agrawal is the director and head of the department at Medical Oncology, BLK Hospital, Delhi. And Geeta is a dear friend who is the head of breast surgical oncology at the Max Super Specialty. And my Sarkar, who is consultant endocrine surgeon at Calcutta, and a former thought leader in the Association of Breast Surgeons of India, former president. Dr. Chetan Deshmukh is likely to join, but I think he has sent his regret, but I will just check with him. And meanwhile, we'll begin today's program. Genomic assays in the management of early breast cancer is the topic for today. I have a very esteemed panel with me.
There is an audio problem.
Dr. Vijay, your voice is breaking.
I will mute myself first.
As recently as 2001, there was this article from wrote an article, who should not receive chemotherapy, and it was a data from American databases and trials. And even at that time, way back about 20 years ago, there was a thought as to which patients would not be benefiting from adjuvant chemotherapy. So some of the thoughts that she has expressed are patients over the age of 70, patients between tumor size 1 to 2 centimeters who are lymph node negative, and patients up to 3 centimeters with favorable histology. So I will ask my panelist, Dr. Geeta, as a breast surgeon, what are the conventional factors you use once the surgery is done, used in deciding the adjuvant chemotherapy? Dr. Geeta, please.
Yeah, so the conventional things that you would use in deciding adjuvant chemotherapy would be size, the grade of the tumor, the ER, PR, and HER2/neu status. That is the usual conventional things that you would fall back on to decide whether the patient requires chemotherapy.
Dr. Chirag Desai, would you like to add anything else?
So traditionally, in addition to all these factors, we also look at Ki-67 nowadays.
Okay.
But yeah, I mean, as the topic is going on, at some point in time, in some of the patient, I would want to look at the genomic of the cancer cells. Basically, rather than the anatomic size or anatomic stage, we also want to look at the biology of tumor nowadays.
So this is a comprehensive list of the various things that people have looked at in the past. Tumor size, lymph node status, grade, ER/PR, HER2/neu, Ki-67, tumor subtypes, presence of lymphovascular invasion, age, menopausal status, and medical comorbidities. I would want to qualify some of these things that are mentioned here. That when we talk about estrogen receptor, the generally accepted degree positive is more than 90%. And that was the level that was used for developing the consensus question. The EBCTCG analysis found that PR was not an important independent prognostic factor in determining response to endocrine therapy with tamoxifen. And sometimes you have a situation where ER is negative and PR is positive. That is considered to be very rare and usually requires retesting and confirmation. Ki-67, as Dr. Geeta mentioned, is very useful in some cancers, especially lymphoma. I wish we had Dr. Sangeeta Desai was to join us with, as she is the pathologist at Tata Memorial, but not at the last minute. But redissemination reproducibility of Ki67 is generally poor and testing methods are not standardized. Clear-cut values have not been defined. Some molecular gene signatures, such as Oncotype DX, include Ki67, but it has not been prospectively validated. The ASCO panel also notes that certain uncommon breast cancer types, tubular and mucinous, have a favorable prognosis, and this could be used in the future for deciding adjuvant chemotherapy, but we need larger data sets. In the past, LVI, lymphovascular invasion, was also predicting poor outcome and has been used as a prognostic factor, but the St. Gallen Consensus Conference felt that it is not sufficient to decide chemotherapy and wondered about its reproducibility. As far as age and comorbidities are concerned, generally we are little less aggressive in deciding adjuvant chemotherapy for elderly patients, and the ASCO panel recommends the measurement of estimated life expectancy and validated geriatric assessment tools. Dr. Rajiv, my question to you is, which are the commonly used genomic assays in your clinical practice?
I think generally if we consider genomic assays, for us it's usually Oncotype DX, both in terms of the availability and also in terms of the use that is adequately backed up by level 1 evidence. So this is what is available. The question of how we use it and whether we use it, I think you will, come to. But essentially, I think for me in my practice, it's Oncotype DX. I have used, I think, EndoPredict once, but beyond that, I haven't had any experience with any of the other genomic assays yet.
Dr. Amit Agrawal, any thoughts on which is the genomic assay that you use in your practice?
I use a lot less genomic profile, but if I have to use either by myself or my patient are quite clear about it, then I've only used Oncotype DX so far, if any.
Yeah, Dr.
I think Oncotype DX has one of the highest validated prospective data available today.
Correct.
And
Dr. Vijay, can I make a point? This is Dr.
The
Sarkar.
other yes, sir.
Yeah.
Dr. Diktendra, please.
Yeah, I have been using of late CAN assist, and I don't have any evidence as of now to predict. But one of the reasons why I would choose CAN assist is because it has got a data which is usually Indian, number one, and they have included cancer stem cells as one of the markers, which is quite recent compared to Oncotype DX, where the cancer stem cell factor has not been included. So in the last, say, almost 6 months or so, I have been heavily tilted towards using CAN assist, and I think we should give this Indian product a chance to actually come out with a robust data.
I think that's a good point, but we still are waiting for larger data from CAN assist to come through. But whatever data they have shown that there is a good concordance with Oncotype DX also with CAN assist. But I still use Oncotype DX, but I am slowly trying to shift patients to start using CAN assist because, like Diktendra said, it has got Indian data, and I think we should encourage something that is indigenous. We can't hear you. Unmute yourself, Vijay.
It seems Vijay has been disconnected.
No, Dr. Vijay.
You have to unmute. You have to unmute.
No, it seems he has disconnected. He has been disconnected. He is reconnecting possibly because of the poor connection.
Okay, I take Geeta's point once again here, and I think it's time that we should run an Indian trial and to generate an evidence how this product actually works. And once again, I re-emphasize the fact that they are using cancer stem cells, which has come up as an independent marker in last almost say around 3 or 4 years. And Oncotype DX has been funding on proteins which date back to 2 decades back. So it's in the beginning of this century that the Oncotype DX markers or 16 of them has been used.
Yes, I will like to join with both of you that I like can assist because it is cheaper and there is a science behind the reporting.
So what
Nobody else has used because I have used it in at least 10 cases and I am happy. I am happy.
So the point
Can I just
only in the long term, you will have to wait out at least 5 years before you can say whether it really worked.
Yeah, Geeta, if you look at the data, only Mama Print has got a sort of... Sir, if I can make a point, if you look at these genomic profiles, only Mama Print has got a sort of prospective data, and the data that comes out with Oncotype DS is completely retrospective, and it is based on PCR. So that's one reason we have to take the data of Oncotype DX with a pinch of salt. And secondly, it was never run in India, so the data is exclusive of Indian patients. So as I said, it's time that we fund more on Indian data.
So Vijay, welcome back.
Welcome back.
Okay.
While he's coming, Chirag, can I just ask one question to all of you that if we want to assess can assist, how do we actually assess it? Should we just use it? And what is the comparator? How do we assess whether it is an appropriate test or not? Clearly, an RCT in this setting is going to be untenable. So how do we just get a large number of patients and then decide what do you compare it with and how do you compare in real time?
So they do have an ongoing validation study going on. While they have gone commercial, they're continuing to do their validation studies. So I think that will be the answer.
So validation studies with respect to Oncotype DX as a comparator, right?
Yeah.
Yes, so they have the ability to do that. So while they're validating their own study, they're also seeing how the concordance is with Oncotype DX. Trouble is, in Indian patients, you will not find many patients undergoing an Oncotype DX. So if I were to tell you the data of my institute, there are about 120 cases in the last 10 years. So, you're not really going to add too much of value in terms of how to establish concordance amongst our patients. But probably you can compare it with the Western data. That's the only place where you can compare it with.
Yeah, it is not going to be possible to do a database trial now for any of the genomic company. So that is first thing. Second thing is that if they continue to enroll the patient on the CAN assist, and if they continue to do the validation with Oncotype or Mama Print, that also is going to be a useful way to look at the validation of CAN assist.
I think, in fact, recommended to the company that they should, for every patient who is done for Oncotype DX, we can also do a CAN assist in some of these patients. And in CAN assist has been done, we can also prospectively check it with Oncotype DX. And that would be a validation study, but of course, it will take a lot of time.
I think
the
Vijay,
only thing I want to say at this point of time is that Mama Print and Oncotype DX are both first generation genome cases. We not taken down tumor.
We are losing you, Vijay, in between.
I think your internet connection has got some issues.
Yeah.
We keep your video off. That will be helpful.
So these are the these are some of the well-known guidelines which have been panels, which is the Mama 70 gene study. There is ProSigna or PAM50, which is a 50 gene study. Endoprint has already been discussed. That is a 12 gene study. That is also done for non-native patients, Dr. Rajiv Bhatt. point I want to make is that for node positive patients, intermediate higher than 31 or higher is a high risk group. For
I think we've lost him again.
Yeah.
So with oncotype node positive, there have been a couple of prospective trials. One is Plan B study in the Germany with 110 patients. There is a SWAP study 8814, and there is ongoing RX Ponder study that will help us in find out whether it is as useful in node positive patients or not. But in all the studies, the cutoff in Plan B study was 11, cutoff in SWAP study was 18, and what they are looking at in RX Ponder study is the cutoff of 25. If you look at the original retrospective analysis of oncotype, the groups were 1 to 18, 18 to 30, and 30 and more. In TASER study, they change it to less than 10, 10 to 25, and more than 25. So it seems that they wanted to go conservative in TASER study. And in the other ongoing study using oncotype platform, again the cutoff is variable. So that is confusing. If we use oncotype DX21, what to interpret and what to take, what not to take. So that's one of the problems with oncotype DX21. With all other genomic tests, including can assist, they are giving good answer whether yes or no, whether it is high risk or low risk. So it is easy for us to interpret. So that's my take on it.
So the TAILORx does give you the opportunity to make it as, to have a low risk and a high risk and a very low risk. When you say less than 11, it's a very low risk. But, under 25, you have the liberty to not give chemotherapy if the patient is over the age of 50. The trouble is when you're dealing with patients under the age of 50, that is where you get stuck. Whether, you should actually believe what, you should go away with the same cutoff. They say it should be less than 15 then, So there is a lot of variability, and I think we keep getting
every
stuck
time
variable.
Exactly. I'm reading the TASER study, I'm getting more and more confused. So
to be very frank, they have not been able to resolve the intermediate or the low risk group. See, it's pretty simple looking at patients who are in the extreme low risk, that they would actually, from your clinical judgment, would not require chemotherapy. But we would like to get a distinction, a verdict for the intermediate group, where actually they are getting stuck. I mean, we are very sure that a screen detected lesion might not be beneficial with chemotherapy, but they are not able to come out with the intermediate zone. That's one of the reasons for it not becoming very popular.
Right.
And I also think the reason why, you don't have a validation on Ki67 is also because, if everybody were to use IHC4 as a surrogate, what will these people do? These big, expensive genomic assays do, because, I have seen whatever little I have seen, the patients whom I've sent for oncotype DX, their Ki67 correlates very, very well. So, sometimes you wonder, whether you should have done it at all or not, or just started hormonal therapy basis your Ki67 levels.
So I just, want to draw your attention to a subsequent follow-up study to the TAILORx by the same authors, that when you have the intermediate risk group, they bring in the clinical factors and the pathological factors to make that distinction. So when you will combine the two, possibly your accuracy will increase. Now, that's like, putting the horse before the cart. Actually, what we want is the other way around, because we want to have selective use of these costly genomic assays. And here we are having an intermediate. We want to come back to the clinical details to help us distinguish the low risk and the...
To that extent, MINDACT is a very good trial.
That's the whole paradox. In my mind, that's the whole paradox.
Yeah, so MammaPrint, if you look at ASCO says MammaPrint for no node negative or node positive, they have, dumped it because probably it's a European thing and, they don't give it too much of it. So there is a lot of bias as it is at our start point, a lot of bias is happening. So, it is very difficult to decide. And like you said, the clinical parameters have come into MammaPrint because MammaPrint also does that low score, high risk clinical, low score, low risk clinical, and those combinations exist with MammaPrint also. And similar with EndoPredict when they did the EpiClin. So they are incorporating the clinical factors which we've always known. So, I think there is a confusion in the mind of the investigators also.
I think Virat, can I just request while, Vijay is coming, maybe we should consider some clinical scenarios just to give an idea to the listeners about, where we use what while we are waiting for Vijay, because I don't know whether we'll get it back.
Recently had a patient, I'll just discuss that with you. She's clinically 2.5 centimeters, but she was keen on conservation. We did a MRI and we found that there was a largish non-mass-like enhancement, which was going from the periareolar region to the axilla. Her core biopsy came back as IDC, but after surgery, what we had was a 6 centimeter area with multiple, most of it was DCIS with multiple foci of IDC, the largest being 8 millimeters, ER/PR strongly positive, HER2 negative, with a Ki67 of 25. Sorry, Ki67 of 6 to 7%. Sorry, 6 to 7.
So, I mean, if you ask me, here for me, the decision is very clear. You've got 3 or 4 factors which clearly show that this patient has an aggressive tumor biology and probably would be clear-cut candidate for chemotherapy.
But she was a T1B.
That's okay, but I mean, Virat can give you, what was the grade on the tumor data?
Grade 2.
Grade 2. Yeah, but you've got a proliferation index.
Another thing that I did not mention was her age. She's a 48-year-old.
Yeah, that again would be a point in favor of going for an adjuvant chemotherapy, I suppose.
So we put it in our NHS Predict, and she came back as benefit of chemotherapy 0.8% at 5 years.
So that's the point. We overestimate the benefit
at 10 years. So that is where the thing is.
Yeah, so that's it. How many of us actually use Predict in our day-to-day decision making? Like you just said, I think. I often use it. Do all of you use it in the same way? If you don't have access to Oncotype DX for, affordability purposes?
Yeah.
So Amit, what is your take on this also? Because, this patient, yes, we did because she's a reluctant chemotherapy taker also. She's quite reluctant to take chemotherapy. Even that is a deciding factor.
Yeah, I agree. So my first reaction when all this discussion was going on, my own personal reaction was not to give the chemotherapy, whatever other people have said so, but with a 8 millimeter tumor, no negative, grade 2, strong ER/PR positive, 48, I agree. I don't disagree with that. But my gut reaction is not to give the chemotherapy. But then it is not my reaction which will decide the event, the discussion between me and her, and in our scenario, the family also, what will go. But my own feeling, when we as a doctor start talking to the patient, on your face, your own gut reaction comes into the picture. You're enthusiastic or non-enthusiastic. So my gut reaction is not for the chemotherapy. The second question is NHS Predict. I use NHS Predict. I used to use that old adjuvant online score, which was great. I use NHS Predict particularly when I'm trying to convince from an inside that, see, you don't need chemotherapy. And the family is gung-ho about taking chemotherapy. NHS Predict comes very handy when you want to prove your gut. Okay, almost always and always, if you go by NHS Predict, you in your own heart you have predicted way above what NHS Predict is going to answer. You will say, see, it's going to be only 3-4%, and then NHS Predict say, doctor, you're stupid. It is only 0.5%. So when you are trying to tell the patient that I don't think you need chemotherapy, but I can't take that call. So let's go to NHS Predict. And then the reaction becomes quite, the patient's mouth is also open. Doctor's mouth is open because he's saying 3%, it is 0.3%. And the patient is like, oh, so it really helps then. Okay, but a 48-year-old lady with a maximal size of 8 millimeters, strong ER/PR positive, grade 2, foolish pathologist, always grade 2. There's nothing like grade 1. They're always grade 2 or grade 3. Not foolish pathology like foolish, but I'm saying in all equivocal cases, it comes as grade 2. 48 is the only criteria. But there are all good features, all good features. But
But Amit, didn't she say that it's around 6 centimeters with multifocal cancer?
No. She said 6 centimeter tumor. Most of it was DCIS. It was multifocality, small punctate lesion, and the biggest lesion was 8 millimeter. I think what you heard was 6 centimeter, but actually it is a T1B lesion.
That's right.
Millimeter lesion. So a T1B node negative, LVA negative, grade 2 lesion, ERPR strong positive. I mean, how much smaller and the better tumor you need to not to treat. I mean, then you need a 0.1 millimeter tumor.
So now Gabbar is back. So let us listen to Vijay.
My point's made.
Vijay, you are there. He is still thinking whether he should start speaking again or not. So while he is thinking about that, let us take another point. Value our pathologist when they are giving the report of AISAI or grade of the tumor. If our pathologist will work day in and day out. Maybe Dr. Dipendra or Dr. Gita, you can start this discussion.
I couldn't actually hear the question because of the background noise from Vijay. Would you mind once again repeat the question, please?
So, how much we will value the assessment of our pathologist in grade or KI 67?
KI 67, as we all know, is a gray zone, and of course there are variations, but I would still stick to more than 14%. Okay, Vijay, you can start.
He is still thinking, it seems. I am talking of our pathologist with whom we have worked day in and day out.
I would always keep my fingers crossed.
Okay.
So I'll answer some part of the question. Can I?
Yeah, please.
Next level.
Vijay, you can start.
Next case.
Password.
GBM.
In the grade, there are three components.
Yeah. GBM. Phase showed in 2020.
Amit, you can continue.
Okay, fine. So in a grade, there are three components. They are called as T, N, and M. So if you sit down with the pathologist, I think I would value when they give a Nottingham grade to talk about clarifying on M, which
Hello. Yes, Vijay, please come back.
Part of the grade. Okay, I can keep off.
Unmute yourself.
Hello. Yes, Vijay, we can hear you.
Next slide.
Sir, I have started sharing your slide. Dr. Vijay?
Yeah.
Sir, I have started sharing your slide here, from here. You just give me the instructions. Dr. Vijay? Hello, Dr. Vijay, can you hear me?
Next, please.
Yeah, next slide.
Next.
Yeah, keep on going.
Next. So the challenge for the clinician is how to use these tests appropriately, utility of these tests in different patient populations, how to best incorporate these tests into daily practice, which test is most appropriate to use, and whether one test has any advantages over another. Next, please. We have already discussed this. Next. 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 So these are some of the studies that the previous speakers talked about in node positive breast patient. There are two big trials going on, which is called RX-Ponder and the Optima trial. The RX-Ponder has hormone receptor positive, HER2 negative patients with 1 to 3 nodes positive, and it plans to randomize patients who are intermediate risk oncotype DX. the Optima is being done for hormone receptor positive, HER2 negative patients, and they have included patients up to 9 lymph nodes, and this is for the ProSigna study. Next. So this is a clinical high-risk patient who has a 40-year-old lady with a T2N1 disease, 3 lymph nodes positive, hormone receptor positive, HER2 negative, grade 2. So my question to Dr. Amit Agrawal, in this clinical situation, will you go ahead with adjuvant chemotherapy or order a genomic assay?
So I would, it's a 3 lymph node positive patient, correct? So I would not order a genomic assay at this point of time.
Okay, next slide. That is probably the correct answer and the way forward, but in case a test is required, the mama print is the most appropriate test in these patients. Based on the prospective data from the MINDAC trial, other tests may be applicable, but their use would be justified based on limited prospective and retrospective data. And the ASCO guidance is specific to mama print for patients with 1 to 3 nodes positive. Next slide.
But would you still use it in a 40-year-old?
Yeah.
I don't think so.
The plan B has also showed excellent outcomes for patients with high-risk clinical features who have a recurrence score less than 11 using Oncotype DX. But for, as Geeta mentioned, that for patients under the age of 50, even in the TAILOR-X study, for intermediate score 16 to 20 or 21 to 25, there is some confusion whether we should be giving them chemotherapy or not. Please bear in mind that the number of patients included in the MINDAC and the WSG Plan B trial, which Chirag spoke about, have a very small number of node positive patients. Next. And therefore, it would be equally reasonable for the clinician, as Amit said, to forego genomic testing and proceed with chemotherapy until further prospective data are available. Thank you. Next slide. Now, this is a 65-year-old lady. She has a T1 1.9 centimeter tumor, hormone receptor positive, HER2 negative, but she has a grade 3 tumor. So, Geeta, what would you do in this case? Plan adjuvant treatment or order a genomic assay?
How strong is the ER?
ER is 90%. The cutoff is 90% and above.
So she's a 65-year-old post-menopausal with a small tumor like that. I don't think we should be paying too much of attention to the grade, you know. I think it is the grade which is driving your thought that, you know, we should possibly do a genomic assay. If you ask me, 65-year-old T1 tumor, I would probably just let her be.
Next slide.
Hormonal treatment.
So Vijay, if I can have a comment. Yeah. So when, you know, sometimes in 2011 and 2013, when in St. Gallen, KI67 was making an entry, at that time, you know, luminal A-like was defined as ER positive and PR more than 20%. So what was the progesterone receptor for this patient?
90% for this particular patient.
Okay. So I mean, that makes us a case for going for a genomic testing.
Correct. Prospective data is available. Both you can use either mama print or Oncotype DX. It should be noted that mama print provides only prognostic and predictive. At this point of time, I would like to make clear that prognostic is what is the 5-year recurrence and 10-year recurrence if it has been tested for that. And predictive is for the benefit of adjuvant chemotherapy and for the benefit of extended adjuvant endocrine therapy. So these are the difference between prognostic information and predictive information. Next slide, please. Next question is to Dr. Rajiv Bhatt. She is a 65-year-old lady, postmenopausal, T1C, 1 centimeter, node negative, ERPR, both are positive, HER2 negative, and it's a grade 1 tumor. Whether you will order an adjuvant and genomic assay or start her on any adjuvant therapy?
No, endocrine treatment straight away.
That is the correct answer. Next
so
slide.
In your last case, you know, Vijay, where the clinical risk is high, and if the mama print is low, you would, so the only thing that was high there was the grade. There was nothing else. Why are you calling it a high risk?
In the previous patient?
Yes.
Biopsy review is required.
Yeah, it is grade 1.
No, the previous one, not this one.
Previous one. So all the parameters, tumor size, nodal status, and the grade.
1.9 and 0, you got 90%.
Features versus the genomic factors.
So if if I were to ask the medical oncologist, what is your, just your gut feeling on the first patient as to what is the benefit of chemotherapy?
So the Gita, the textbook answer is Oncotype DX. The textbook answer is that, but the gut feeling is I would be reluctant to offer chemotherapy of the thing. You should take chemotherapy. I would not be really suggesting that. If you want a textbook answer, it's Oncotype DX, but 1.9 centimeter strong ER positive, PR information not provided, what was rightly talked about. If PR was also more than 20%, add another value of KS67 of 8, 9, 10, 11, 12%. I would not give value of grade 3 so much that I would rush for chemotherapy.
Correct. So genomic profile may be less applicable for this patient given the small tumor size, which is what Rajiv Bhatt mentioned, low grade, high hormone positivity, and genomic testing is not considered cost effective in this setting. So what this panel discussion is talking about is categorizing patients into low risk and the intermediate risk and the high risk. The high risk obviously go for adjuvant chemo. It is a small subset of patients in whom this genomic testing needs to be advised, and those are the ones who will be categorized based on the genomic assay results, whether they will benefit from adjuvant chemo or not. Next slide. Next. Yeah. So next slide, please. The previous slide said that in case you do a mama print and it comes out to be high risk because it was clinically low risk and genomically high risk, then they do not, even in those subset of patients, if you do a mama print, there is no benefit of giving an adjuvant chemotherapy. So again, she will receive only hormone therapy, as Dr. Rajiv Bhatt mentioned. So now this is a 48-year-old postmenopausal woman who was perimenopausal at the time of diagnosis. Her tumor was 2 centimeter, grade 3, 1 positive node. She subsequently received adjuvant chemotherapy and has just completed 5 years of adjuvant tamoxifen. Dr. Chirag, will you stop endocrine therapy now or continue tamoxifen or aromatase inhibitors for 5 years or order a genomic assay?
So there is no point in ordering genomic assay at this point in time. That's first thing. Second thing is the trial is ongoing, where circulating tumor cell assay is being tested at the end of 5 years to decide whether hormone therapy should be continued or not to be continued. But there is not mature data yet. So as of now, I will be giving all patients 10 years of hormonal therapy, not 5 years of hormonal therapy.
Even for the low risk patients, or will you do a genomic assay just in case to find out whether they are at risk of late recurrence?
Not really. I mean, 5 years or 10 years will not be answered by genomic assay. It is said that the second generation genomic assays are looking at the 10 years survival, but that data is not so very convincing. I mean, on the very first day only, I am deciding whether I will give the hormone therapy for 5 years or 10 years. So node negative, I might stop at 5 years, but more and more data is coming up, more for tamoxifen as well as letrozole, that 5 years of tamoxifen or letrozole should be followed up with further letrozole.
Correct. So in case it's a high risk patient, you might not order a genomic assay in this subset of patients and might continue adjuvant endocrine therapy for at least 10 years.
So this patient is a candidate according to the MA17 also. This is that subset which is likely to benefit from prolonged hormonal treatment.
Exactly. So this is a MA17 trial which said that those who become menopausal experience a greater than 70% risk in reduction in recurrence with the addition of letrozole, and there is a benefit of extended endocrine therapy, and genomic tests are generally not used to determine the benefit of extended adjuvant endocrine therapy, is what Dr. Chirag Desai was talking about. Next, please. This is a 64-year-old lady, postmenopausal, T2N0, hormone receptor positive, HER2 negative, grade 2. She has received 5 years of adjuvant tamoxifen. Will you extend adjuvant therapy with an aromatase inhibitors for 5 years? This is a low-risk patient. The concerns here are the fear of adverse events versus the fear of late recurrence. By adverse event, I mean the side effects of extended aromatase inhibitors for beyond 5 years. Dr. Amit, in this subset, will you continue a hormone therapy or order a genomic assay?
Oh, I would not
Next.
order a genomic assay if that is the question. My question is only based on this information. Am I going to give
Next.
I'm done.
Yeah, Amit, go ahead.
Okay, so next was not for me.
No, sorry, not for you, not for you. We have lost.
Yeah,
Go ahead.
Okay, so my question is not about genomic. My question is T2N0 65-year-old female. This is a patient who is a low risk patient, strong ERPR positive. My question, should I give more than 5 year or not more than 5 year? If I'm inclined to give more than 5 year, I'm more happy giving tamoxifen to 65-year-old lady than to give letrozole and astrozole, because these are the patients who come back with a lot of osteoporosis and a lot of joint disorder, and they become quite uncomfortable with their quality of life at the age of 68, 69. So either I would do nothing or I would continue tamoxifen for 10 years.
Thank you very much. Next slide, please. So we have already talked about the CAN assist breast. I think Dr. Chirag Desai is one of the authors of one of the recent publications of CAN assist. It has 5 biomarkers and 3 clinical parameters, including tumor size, grade, and node status. Grade, Dr. Geeta, as I told you, has been included among the 3 clinical parameters, which is why I was referring to a grade 3 tumor previously. Based on that, a CAN assist score is generated, and if it is low risk, the cutoff is 15.5. Then those patients receive only adjuvant endocrine therapy. If it's a high risk patient, they receive both chemotherapy as well as followed by endocrine therapy. And as you can see in the graph there, the difference in 5-year survival between CAN assist low risk and high risk is very clearly demarcated. It's a large study of about 14. This is the data that they have from about 1,400 patients. Next. We will be having Dr. Somshekhar and Dr. Sudeep joining us in the next program. Dr. Doval, they were the authors of this article which came out in Cancer Medicine. And you can go through this article, and that will probably answer a lot of questions about CAN assist, which is the Indian genomic assay. Next. In my recent approach to this panel discussion, I came across this interesting article by Sperano, who is one of the authors for the Oncotype DX. And this article was published in 2019, where he said that there is a rule of 4, that is more than 3 centimeters grade 1, more than 2 centimeters grade 2, and greater than 1 centimeter grade 3. These are some of the thumb rule that you can use in planning, where you can combine both tumor size and grade and come to some sort of consensus and evolve the adjuvant treatment for your own patients. Next.
I think this was for the less than 50 year age group.
Correct. My question to Dr. Rajiv, what are the limitations that you see in ordering a genomic assay?
I think the biggest limitation for us is currently the cost and the accessibility of the test. For me, that is clearly the biggest limitation. The second, of course, is that we don't have Indian data. There's an issue with the intermediate risk group. We really don't know where to go with that. So although we have level 1 evidence, I still don't think that it's complete to make decisions on the ground. And as I said, accessibility issues is a major problem.
Dr. Diptendra, my question to you is, in what percentage of your patients has a genomic assay changed the treatment plan? Dr. Diptendra, my question to you is...
Yeah. So in my personal series, it has been maximum 10% of cases where it changed the treatment plan. Most of the time, it just gave me an objective evidence to suggest that yes, what my gut feeling was is having a concordance with the CAN assist data. That's it. But otherwise, in only 10% it varied. We have not done any retrospective study to assess which should be the center of study to begin with at present. You get a large sample size of 5,000 plus, get the samples and go back and try to find whether it was the way Oncotype DX did it. In my practice, only 10% changed.
I think, as you mentioned previously, ethnicity could make a difference. Dr. Chirag, my question to you is, how confident are you in using it in node-positive patients, and is the data robust enough?
I don't think so. I mean, the data is not robust. I'm not confident in using it in node-positive patients.
Okay. And Rajiv or Amit can take this question. Is it cost-effective to be applied from a health economy analysis point of view?
I think I already mentioned my viewpoint. Amit, you can go ahead.
Next.
The Vani Parmar has a point to make.
Yeah, Dr. Vani, you can come in now.
Yeah, I was just waiting to be allowed to speak up
Inducted.
I have a little concern on CAN assist.
Okay.
So if you look at CAN assist data, the way it was worked out, in fact, 60% of the patients that were included in the 230 data set that got analyzed for validating it, or the first test set that was there, was actually a node positive subset. There were high grade tumors, it was node positive, and in fact, poorly differentiated in 42%. So as I see, there is a big concern. 10% of them are actually T3 tumors. Now, if you're going to start a genomic, I mean, if you're going to do a set that is being tested in a set of patients where you're never going to be using it, you will automatically, by virtue of the clinical factors of tumor, lymph node, as well as the high-grade features, will divide the whole data set into a poor risk and low risk. You don't even need another test or genomic assay to tell you that it is a high risk and low risk. It automatically divided itself. So starting from there, if you're taking that test and applying it now to a node negative and expecting it to divide it, I think it is too much of a variation that you're looking at. I'm not even sure. And I think, like Geeta said very clearly, we need to validate this, and it has to be validated in a large data set against the known clinical factors. Until such time, take it with a bag of salt. I don't think it is ready yet to be taken into the clinics. It has got its approval by whatever means, and I'm not even questioning that or discussing that in this forum. But I think we really need to, as clinicians, first understand that you have a test that has really not been validated in or developed in the set of patients that it should be developed in. It has been developed out of a set of patients which are automatically divided into a low and high risk. And you don't want to then apply it into a smaller data set of, where it's node negative, lower grade tumors. And I think, Amit, I'm not sure how comfortable you are in using CAN assist, and Geeta is very right. You have to validate it before you start applying.
Agreed.
I don't use CAN assist.
Sir, if I may interrupt, I'm sorry, we'll have to
I will
close this panel in 2
5
minutes.
As this slide shows that there is a pre-recurrence score. It's hardly about no change in about 67% of patients, in about 33% of patients. 27, the change, the genomic assay provides from chemotherapy hormone to hormone, and it shifts from hormone to chemotherapy and hormone. So that is a change. Next slide, please. Next slide. So those of you who are present at the second Navigating Clinical Conundrums in Breast Cancer 2019, these were some of the points made by Dr. Sudeep Gupta. He said regarding the MINDAC trial, which had about 6,700 patients, the number of node positive patients were about 20%, and based on that, we are extrapolating that data into our clinical practice. So I entirely agree with what Dr. Vani Parmar has said, that we should look at the patients who are included in the study for the developing the algorithm. Next.
Sir, we also have a question from the audience.
I will just finish this and then we'll take the questions all together at the end. Oncotype DX, of course, has been the most validated with 125 clinical studies, more than 1,40,000 patients studied with 156 publications, and they claim to have saved about $5 billion in healthcare cost, saving in chemotherapy, side effects, long-term complications of chemotherapy. They have even developed the Oncotype prostate, Oncotype colon, and we have now an Oncotype BCIS also to whether, but that is not part of today's study. Next. This is whether talking about cost effective, Oncotype DX is cost effective for patients with intermediate and high risk ER positive HER2 negative patients, but not for low risk clinico-pathological correlation is available in current practice, and it should be integrated into Oncotype DX and chemotherapy decision-making processes. And cost-effective analysis ignoring clinico-pathological information are problematic, and they might result in inappropriate conclusions. And we need further randomized controlled trials to provide more efficacy, effectiveness estimates for these genomic assays. Next. I conclude by pointing out what Senthil said in repartee to what Dr. Sudeep Gupta has said, that let's gracefully move on to the future, let's search for alternatives, no prospective validation on prognosis, no prospective data on predictive value, biases of the registries, which is what we were talking about, overestimation of benefits in elderly patients, underestimation of survival in younger and small aggressive tumors, lack of standardization of clinical utility, and seems worse on performance compared to tools which are not. Next. So to conclude, genomic testing is generally only indicated in patients with hormone receptor positive, ERPR, HER2 negative patients and up to 3 positive nodes. 3 positive nodes, as Chirag pointed out, we should be very careful in suggesting a genomic assay not to be used in patients with hormone receptor negative. More than 3 nodes, HER2 positivity, triple negative outside of a context of a clinical trial, generally not to be performed in patients in whom the testing will not affect the course of treatment, which is what Dr. Rajiv Bhatt said. Importantly, neither ASCO nor NCCN guidelines currently imply the superiority of one genomic test over another, and discordance between available genomic tests is expected because the different tests were developed and validated across a range of patient populations and treatment background. So I'm not sure how we will be able to conduct that randomized controlled trial also, which we were talking about. Performing more than one genomic testing on a patient should be avoided, as uncertainties and risk assignment may take place. Next. Thank you. This is the team at Asta Oncology Associates HCG Cancer Center. Next. There are a lot of questions. I think it was a very interesting panel discussion. I thank all my panelists, and there will be some questions. You may have stumped me with that question, but I think the wise man also says that there is something that you need to Google and read all these articles and go to their publications to find out that which is the subset of patients that have been included and the conclusions, and read the criticisms also which have now available regarding these particular trials. Thank you very much for a very interesting and highly participative panel discussion.
Thank you, Dr. Vijay. It was a very interesting session. But I just wonder that all this thing, Oncodes and Mamaprint are from USA. Any of the research lab in the country, either at Tata Memorial or the All India Institute of Medicine or the Science and Technology Department in each state, Chirag is associated with Gujarat Science and Technology Mission. They can take up such projects so that more patients from India can be taken up. Now, Can Assist is also a corporate activity. It is not a social activity. So for us as a group, we should demand that all such activities are needed for the country. We have not to depend only on ASCO all the time. And now we move to the another very important aspect of the breast cancer, that is escalation therapies in triple negative breast cancer. The moderator for the panel is Dr. Prasad Narayan from Bangalore. He is senior medical oncologist from the Cytocare Cancer Hospital. Over to Dr. Prasad.
Good evening. So it's a pleasure to be part of this meeting. The panelist for this talk will be my teacher, Dr. Sudeep Gupta, sir. It's great to have him on a panel actually, rather than being on the panel when he is moderating a session. Then the other panelists are Dr. Mansi Shah, Dr. Aditya Murali, Dr. Gautam, and Dr. Sanjeev Shah. Dr. Bharat has sent his apologies, he couldn't join. So I'll try to share the screen. Is the screen visible now?
Yes, sir. It's visible, sir.
Yeah, visible.
Right. So the topic will be escalation strategies in triple negative breast cancer, non-metastatic disease. And this case actually came in the medical oncologist's WhatsApp group actually. One of our colleagues had posted this group and asked for opinion. So that obviously made my life easier for this panel discussion. But I thought that there were some interesting discussions which happened on that. And I have taken some points from there and thought that we will drive the panel discussion through those points. So this is a 28-year-old lady with a breast lump. And the clinical diagnosis was a triple negative breast cancer, T2N1 M0. So the first question discussing is the role of BRCA testing at baseline for this patient. And can I ask Dr. Mansi to take up that question?
Yes, sir.
Yeah. So
go ahead, sir.
Yeah, will you get a BRCA test done for this patient at baseline?
Yes, sir. I think I would like to get the BRCA testing done at baseline because you know, she's a 28-year-old young female, and it would have implications in terms of offering her treatment options for the patient herself, in terms of offering BCS versus mastectomy, prophylactic mastectomy, and risk of ovarian cancer discussion. So that is number one. That is from a genetic and a therapeutic standpoint for the patient herself. And the other thing, you know, that would also be interesting to know is in terms of addition of platins in this patient, if she turns out BRCA positive.
Right. So we will take that up in the discussion point. And is there anything like an HRD testing in TNBC? There is I will share one of the clinical trials which randomized patient based on HRD testing. Can any one of the panelists take up this question? If Aditya is there.
Yeah. Thanks, sir, for having me here. So see, as such, there is no validated use of HRD testing in breast cancer, at least to my knowledge. But I know that, logically speaking, if we have proven it in ovarian cancer, we should be able to extrapolate it in triple negative breast cancer. The problem is that, triple negative breast cancer is such a wide, it's not one single entity. There are so many sub-entities that we won't know in whom to actually advocate this HRD testing.
So, Dr. Sanjeev, can you can you throw some light on HRD testing from a pathologist point of view?
Sorry, HRD testing, huh?
Yeah.
Yeah. Sorry, I missed that lecture because I have one call.
So
what is stand? Hello, what is HRD?
Homologous recombinant.
So I think we'll take it up later during the discussion. Okay. So this patient turned out to be BRCA positive. BRCA2 was positive, and now with this result in hand, will this change the initial treatment of this lady in any way? If anybody feels that it will change, they can discuss that. Otherwise, we will go ahead with the case.
So can I add,
right.
Dr. Prasadam?
Yeah.
So young patient BRCA2 positive. I'm assuming that I think she's clinically T2N1, so we would offer her neoadjuvant therapy at this point.
Right.
And in terms of the neoadjuvant therapy, there is some data to suggest that adding platinums in all triple negative patients, and especially in patients who have a germline mutation, might be beneficial in increasing PCR.
Okay, so we will come to that point. I will take it up with you about the role of platinum. So you feel that the BRCA positivity will decide your initial treatment in this patient. Anybody, Gupta sir, do you think that this will change your approach in the initial treatment of this patient, initial choice of chemotherapy?
I don't think I will necessarily change any treatment based on the BRCA report.
Sure, sir. So So this patient got 4 cycles of AC, and unfortunately, there was negligible clinical response, and was changed to 2 weeks of paclitaxel, and there was clinical progression for the patient. So at this point of time, what is the best option for this patient? This is still a resectable breast cancer. Is it surgery or further escalation of chemo? This is a difficult case to take. Anybody will opt for escalation of chemotherapy at this point, or the panel will go for surgery at this point? Gautam, can you take it, Gautam?
Yes, sir. I will straight away jump for surgery, sir.
Surgery.
Rather than escalating for chemotherapy, because we never know, sir, it will work or not. So I will go opt for the local regional therapy, that is surgery, at this point of time.
Anybody for escalation here? Very difficult case to take. So we will assume that everybody would go for surgery, and then mastectomy was done for this patient, and it was a YP-T3-N1-M0 multifocal grade 3 disease. So there is a definite progression of disease here. And now this is what came in the WhatsApp chat. I will just read it out, and then we will take up the panel's position. The first medical oncologist said that they would give paclitaxel carboplatin and finish the paclitaxel weekly protocol, followed by radiation, and then capecitabine for 6 months. She's BRCA positive and does the ovaries also. Second medical oncologist said no paclitaxel because the patient was progressing on paclitaxel. Definitely yes to capecitabine and RT. And there was a suggestion which came about immunotherapy here. No immunotherapy. Carboplatin, that person was thinking, go with what your gut says actually. So the next medical oncologist feeling was that the adjuvant carboplatin feeling, the strength of the feeling is inversely proportionate to the evidence, which I think we should discuss in detail. And it was validated by our another friend who said we intend to use carboplatin, but the data does not support it. And another medical oncologist's opinion was that both the capecitabine maintenance or concurrent pembrolizumab data are both as dodgy as they can get. So interesting take on this. So we will take up these 4 points here, and I will request Dr. Gupta sir to actually give his comments on all the 4 points after our other 2 panelists take it up, because actually it was like a debate which I planned, but since one person dropped out, we'll try to adjust among the others who are present. So the role of platinum will take up with Dr. Mansi and Aditya. The role of PARP inhibitors, Dr. Aditya and Dr. Gautam. Then the role of capecitabine or metronomic therapy, Dr. Mansi and Dr. Gautam, and the role of immunotherapy, Dr. Mansi and Aditya. So let us discuss this, why we are so much concerned about neoadjuvant approach in triple negative breast cancer. Because of this, that if you have a PAT-CR versus no PAT-CR, definitely the outcomes are much better. So that is where Dr. Mansi came in the beginning. When you take up the studies from carboplatin in triple negative breast cancer, there is definite from different studies. They have used different partners in terms of different types of chemotherapy, comparing adding the platinum versus gemcitabine, adding bevacizumab and platinum, and it was always found that there is an increase in PAT-CR with adding carboplatin. So with this, I will go to Dr. Mansi. You can put your thoughts in favor of adding platinum as an escalation strategy in triple negative breast cancers.
Sure, sir. So, I mean, I think I kind of go with the PCR argument. That is the first thing that, as you showed, we do have phase 3 trials suggesting that carboplatin does add to PAT-CR rates. Probably maybe about 15% difference in PAT-CR rates, depending on what study you look at. Now, that means that, so I guess there are 2 schools of thought. One school of thought that feels that PAT-CR helps us treat further management, like decide if the adjuvant treatment is going to change or not. And so in my mind, if a patient is at a higher chance of getting a PAT-CR in whatever way you get there, the chances that you would have to give her adjuvant treatment, if you're going to decide your adjuvant treatment based on the CR rate, would change. So for example, if I have a higher chance of obtaining a PAT-CR by adding carboplatin to a patient, which is seen in the CalGB study, the JAPAS 6, so there's also the brightness trial, which looked at addition of carboplatin in addition to PARP inhibitor. About 20% patients will have an increased rate of PAT-CR. That means those 20% patients, I would not change their adjuvant therapy in terms of metronomic capecitabine. And also,
So
I think
you are banking on the PAT-CR to decide for adding platinum, right?
yes.
Right. So I will come to Aditya. Can you put your thought and say something what is not there by adding carboplatin?
Yeah, sure. So let me start with this case. In this case, for some reason, things are not adding up. We expect, BRCA positive patients to respond to treatment. So she's not responded to chemo, which is quite obvious. So, so maybe in this particular case, I would be in favor of adding another agent because ultimately, we have to use all our weapons upfront if we have to have any chance of salvaging this. Otherwise, this lady is definitely going to relapse quite soon. And maybe, although I'm arguing against using platinum upfront, at least in the neoadjuvant setting, in this patient at least I would probably have considered. Anyways, to come back to what Dr. Mansi has said, I mean, few points to refute what she has said. Let's start with GEPAR-62 because I think that has been quoted quite often here. GEPAR-62 we know was basically a phase 2 study. And you see, this study showed that even after we had a dose reduction of carboplatin from AUC 2 to 1.5, still about 70% of the patients had a grade 3 or 4 hematological toxicities, and nearly 48% of the patients had to discontinue the carbo dose. Now, if we put these numbers in the context of an adjuvant setting, somewhere I think we are missing the ball if such high numbers are there in an adjuvant setting. The CalGB trial was again quoted. CalGB, I think 5-year EFS and OS analysis was published in JCO last year, which absolutely showed no difference.
Right.
So I do concede that there is no, I mean, PAT-CR rates will improve, but there has to be a reason why this did not, even though the trial was not powered, but there should be a reason why this did not translate into that benefit. So given, all this slightly sketchy data, still not very convinced in, changing the upfront regimen of AC taxanes.
Okay.
Can I just add to that? I'm sorry.
Yeah, please. Yeah.
So for the GEPAR-62 trial, the chemotherapy backbone was like carbo, liposomal doxorubicin with paclitaxel. I mean, we really don't use lipodox and paclitaxel and carbo together. So I think that is one of the things that we should keep in mind in terms of the chemo backbone that was used for looking at toxicity.
Right. So, sir, Gupta sir, so you said, I have to ask you 3 questions actually. One is the comment on the role, if a patient has progressed clinically on 2 weeks of paclitaxel, there was a comment that whether we should continue paclitaxel in that patient. That's the first question. The second question is whether you go with platinum specifically because the patient is BRCA positive here, or you go with platinum because the patient has not responded to AC and paclitaxel. And thirdly, the whether carboplatin actually adds to the survival or it just gives PAT-CR rates. Hello, sir is not there, or I can't see.
Sorry, sorry, Prasad. Sorry,
No.
I muted myself.
Yes, sir.
I'd said that thank you for asking me those questions, and my ability to answer is declining these days, but I will do the best that I can. Your first question was about whether I would like to continue with paclitaxel or stop paclitaxel after 2 weeks if there is disease progression.
Right.
My own clinical sense is that in an occasional patient, you can see clear disease progression within 2 weeks of starting any treatment. But more often than not, to make that judgment in just 2 weeks of treatment is often not possible.
Agreed, sir.
So, one should not really change a treatment unless one is completely certain that that treatment is not benefiting, especially because this woman has already proven herself to be resistant to anthracyclines.
Right.
So that's the first answer to your question, that if I'm not certain and if the progression is equivocal, I would perhaps continue with paclitaxel because anthracyclines and taxanes are the best shot that she has.
Right.
Your second question is that whether I would like to add platinum in this woman because she's BRCA positive or because she's resistant. I would agree with most of the other panelists who said that they would perform surgery in such a patient at that point of time. And after surgery, I must confess that without much evidence, I would possibly offer her platinum, primarily driven by the fact that she does have a BRCA positive status, and therefore, my impression would be that she would respond somewhat better to platinum.
Sure, sir.
There was one comment that I wanted to make. We have to decide whether we are thinking about escalating treatment at time zero, at time point zero, or after the end of neoadjuvant chemotherapy in poor responders. At time point zero, I agree with the contention that was made that even though the addition of platinum has improved pathological response, there is actually no good evidence at this point of time that it actually improves disease-free survival. And we could debate some of those points. There was also a subsequent publication of the JAPAR-6 data in JAMA Oncology, which showed that actually it was the BRCA positive patients who did not benefit in terms of survival, even though they did have an improvement in PATH-CR, although the numbers were very small. So at time point zero, we ourselves have completed a large randomized trial of about 730 patients in TMH, and we will soon be presenting the data. But until we have good evidence, I don't think that we should say that we can add platinum at time point zero in patients either with BRCA positive disease or in all triple negatives. The next question is patients who have had a poor response to neoadjuvant chemotherapy. I think the best evidence to date is the CREATE-X study, and that suggests that addition of capecitabine might help in improving the outcome in some of these patients, especially those who are triple negative. Now, in this patient, the toss-up between capecitabine and platinum, I think the better data is for capecitabine, but maybe, some of us will give her platinum because she has a BRCA mutated state.
Right, sir. So that's a great summary, and that was what the chat also said. Actually, the feeling for platinum is so much here, but the evidence is not that strong. Actually, I think that's great. So let us move to the next one, and that is the PARP inhibitor data. We have multiple trials. We have the trial with the veliparib. We have the trial with talazoparib. And this is the data which I was speaking about, looking at HRD in triple negative breast cancer. And this was a trial which was actually designed by looking at the HRD. And since I was interested, I thought I will just discuss this trial as well. This actually had, there was a randomization between cisplatin versus paclitaxel in the preoperative looking at HRD. And the trial actually concluded saying that there was no winner overall based on HRD in this actually. And cisplatin response do better for HRD tumors, but taxanes show no difference. So here I will discuss about we will be discussing about the PARP inhibitors as an escalation strategy in triple negative breast cancer in the early stage. We have data in the late stage. We don't want to discuss that. So Aditya, can you take up this question about PARP inhibitors? We have a patient here who is BRCA positive, and we have PARP inhibitors which are available. Will you considering the fact that this patient has not responded well to the treatment, PARP inhibitors addition here?
So, of all the data that we have now, we need to choose either between using platinum or choosing capecitabine or going with one of the PARP inhibitors. Of all the data, as Dr. Sudeep said, the best data is still for CREATE-X and capecitabine. Now, would I want to choose capecitabine first, or would I want to choose PARP inhibitor first? Definitely the data supports choosing capecitabine first. If capecitabine is also not there, hypothetically speaking, yes, PARP inhibitors are supposed to act in this setting, but data at present probably does not support it.
Gautam, can
Yes.
you take up the PARP inhibitor question? Do you want to use PARP inhibitors? If yes,
frankly, no, sir.
No.
In future, might be yes, but not at this point of time because of the scarcity of data, and might be I'm just thinking capecitabine and PARP inhibitors comparative trial will give us better idea. It might be in future, not at this point of time, not at all.
So Gupta sir, what is your take on, do you predict, like you have put your neck online during the last talk, which I heard you many times actually, predicting so many things. Do you think PARP inhibitors will play a huge role in early breast cancer therapy?
So, when it is time to put my neck on the line, it means that it is also time for me to retire. And that is why I prefer the role of a chairperson these days, because I become more of a soothsayer than a purveyor of data. But again, let me stick my neck out because you baited me. You see, if you look at the data of PARP inhibitors in metastatic breast cancer, and all of whom were G-BRCA mutated, the efficacy is much weaker than it was in ovarian cancer. And that could be because of a variety of reasons. There are some biological reasons, and triple negative breast cancer is not completely synonymous with, or not very completely biologically similar to high-grade serous ovarian cancer, despite their gene expression profiles overlapping.
Right.
May not play a great role in the treatment of non-metastatic breast cancer, either G-BRCA mutated or somatic BRCA mutated or HRD positive.
Sure, sir.
I just want to add one point. Somebody talked about HRD. So HRD is essentially homologous recombination deficiency, and essentially the tests that measure this look for widespread damage throughout the genome. And the one test that is in use in ovarian cancer essentially looks at telomeric allelic imbalance, loss of heterozygosity, and other marks, and this is genome wide. So essentially, if DNA is disordered at many different locations, including allelic imbalance, loss of heterozygosity, it means that DNA has deficient capacity to repair itself. And while that has proven itself to be a reasonably good predictive marker in ovarian cancer, I am a little doubtful that it will play a role in breast cancer. I don't think that they will achieve the same level of success.
Right, sir. I think that sums up the discussion. And also it is noteworthy that the platinum benefit, when the trial of platinum plus PARP inhibitor was done, there was no additional benefit in BRCA mutated patients if they got platinum actually. So the PARP inhibitors did not help much there. So maybe, as you said, this will not be an escalation strategy for us, but we can wait and watch. So we will go for the next topic, next point which was discussed in this, and that is the most interesting topic for all medical oncology talks these days, that is immunotherapy. And we have data from all the 3 immunotherapy molecules which we are using in the neoadjuvant setting, with some improvements shown in it's easy to design a trial with PATCR as a hard endpoint. So all these trials have looked at that, and we have data on durvalumab. We have the pembrolizumab data, which has been more and more published. I don't know why there is a lot of thrust on that. And we have atezolizumab data as well. So again, the endpoints here where the PATCR and the event-free survival has not been mature, I think, for this study. So we will go for this immunotherapy as a escalation strategy in triple negative breast cancer, and I'll request Dr. Mansi to take up this first.
So I think there's a lot of interest in basically trying to improve the outcomes of triple negative breast cancer patients, and hence there are all these new drugs that people are trying in the early setting. I think one of the rationales for bringing immunotherapy up front is in the metastatic setting, it was shown that in the second line, immunotherapy does not work that well. Maybe the tumors become kind of the IMPassion 130 looked at atezolizumab first line, and hence there was this whole thing that if it works first in the neoadjuvant setting. So for all these trials, if you look at the PATCRs again, there is a clinically significant improvement in the PATCR rates, again in the order of like around 15%. And in the first trial, the durvalumab trial that you showed, I think it was interesting to note that the patients who had durvalumab before starting chemotherapy tended to have a higher PCR rate. However, all these trials, they are too immature, I feel, in terms of looking at long-term outcomes. So there is no definite benefit in terms of event-free survival, let alone overall survival. So I think the data is exciting. We of course have to take it with a pinch of salt, to see how they do, because the immunotherapy, as we know, is not entirely non-toxic. It can have long-term side effects, unlike chemotherapy, which are usually transient side effects.
Okay,
So again, I think we are chasing PAT-CR again, right?
And you suggest that we be mature enough to wait for the data to mature, right?
I
And
think
do
so.
we actually do any PDL1 testing or MSI testing or something in patients with triple negative breast cancer? Since that is the so this I can ask Sanjeev actually. Can you talk something about the PDL1 testing in triple negative breast cancers?
Yeah, we see we are getting almost 15-20 cases of PDL testing in triple negative breast tumors. There are two main platforms for this testing. One is DARCO and second is from Roche Ventana. Both has two clones. In the breast, they have studied 3 different clones. One is DARCO 22C3 and Ventana SP263 and SP142. But what study says that there is a best prediction of response to immunotherapy with SP142 at a cutoff of more than 1% for tumor area. These results are different according to different site. If you say the liver, metastatic tumor in liver, most of metastatic TNBCs are inert. They don't produce any immunity. So all of tumors which I've studied in the liver is almost less than 1%. So what I do, whenever there is a blocks of both primary and metastatic tumor, I check SP142 on both primary and metastatic side. And my experience is that there is a highest result with metastasis in the lymph node, second in a primary breast, and the liver is the least immunogenic. So whenever you have 2 blocks, I will study on the both.
Okay.
Even we have found a positive result in the ovarian metastasis also.
Right. So I think we'll move ahead. So Aditya, can you discuss about your take on the immunotherapy? Do you think that we have mature data or we want to mature?
I definitely want to mature more.
Okay.
But one interesting thing is that this keynote 522, most trials with pembrolizumab, they actually started off, stratification right at the beginning based upon the PDL1 status, and they tried to concentrate on getting the biomarkers right, wherein they could predict a response. This was the one trial wherein they did not look at the biomarker upfront. So even if we do get to using immunotherapy someday in neoadjuvant setting in breast cancer, if there is a biomarker, that would definitely instill more confidence to use this in a neoadjuvant setting, I guess.
Sure. So
Can I
come to Can
I interrupt?
Yeah.
So there are the reports that even the tumors is less than 1% cutoff also responds to immunotherapy. So apart from PDL1, there are immune markers like CD8 positive T cells and other. This one, NanoCS came up with the immunoprofiling panel to predict the response to immunotherapy. That I don't think is easily available. That immune profiling panel.
So, Sir Gupta sir, so what is your take on this, sir? The immunotherapy, do you think it is something which is interesting?
Sorry.
Yes.
I definitely think that immunotherapy is interesting, but like everybody else, I also think that we need more definitive data before it enters clinical practice. I just want to make one brief comment on PATH-CR. Actually, that PATH-CR is prognostic, is undoubted, and everybody knows about it. The question when you're evaluating a new treatment is whether the increase in that PATH-CR, and the increase means the delta. So, if you increase the PATH-CR over standard treatment from 40% to 52%, the question is whether the 12% improvement in PATH-CR will result in some sort of an improvement in long-term survival. So, that is where the whole game is. And that is where many of the treatments that do improve a PATH-CR eventually fail. And there's a very nice paper by Don Berry and Cliff Huddis in JAMA Oncology a couple of years ago, where they showed that, you know, the delta in the PATH-CR has to be substantial for you to expect a long-term improvement in disease-free survival. So, you know, I believe that in this keynote 522, the PATH-CR improvement is about 19 or 20%, which may actually correspond to some improvement or a meaningful improvement in long-term survival. But you know, if the PATH-CR is improved by 6% or 8%, even though by itself it may be statistically significant, it may not correspond to some kind of a long-term improvement in DFS. And this is the same sort of an equation and argument that radiotherapists make when they say that for every 4 local recurrences raised, you save 1 life. So there's a ratio between preventing loco-regional recurrence and eventually translating into survival. So PATH-CR by itself is not the point. It is that the increase in PATH-CR will result in what degree of improvement in long-term survival.
Sure, sir. Point taken. So we will go to the last point, and that is the, I think, where most of the people say that there is data available here. This is the post-neoadjuvant escalation. So if you don't get a PATH-CR, you can escalate by giving capecitabine. Is the study which everybody talked about, and has it changed practice? It has changed practice in some situations. So we will take up this study. So Dr. Mansi, what is your take on this?
So I think this is where I was getting at initially in terms of for patients who have a high residual cancer burden post neoadjuvant therapy, I am tempted to use capecitabine as a maintenance, like the CREATE-X trial did, because it did show an improvement in the overall survival. I mean, I do use this strategy more in patients who have multiple nodes positive or had a very poor response to neoadjuvant therapy, with the hopes that I think we always feel that by doing something, we are adding more to the patient's outcomes. I'm not sure if that is true or not, but at least based on the CREATE-X data, I am kind of inclined to look at this.
So, Gautam, you have something to say about this? Something against the role of
no, sir. No, any valid points, sir.
You can always find something against every data. Yeah, you should find out actually. So
I think there was some. I'm sorry.
Yeah.
I think there was some suggestion that it might work better in Asian patients. Like, I don't know if ethnicity works, because there was another Chinese trial that came up looking at maintenance capecitabine, and I don't know. The GCAM study, I think that there weren't a lot of Asian patients.
So I think we can summarize. We have only 1 more minute to go. So I will summarize, and I will ask Dr. Gupta sir to say whether this is fine as a conclusion about these 4 points. One is that the routine use of platinum hasn't translated to improved survival, and the correlation of PATH-CR with survival hasn't been consistent. And the present data doesn't support PARP inhibition or immunotherapy in the early stage disease, and capecitabine maintenance can be considered in patients with residual disease post the standard therapy. So when you say standard therapy, there is no data to say that if you are given a patient AC and paclitaxel carboplatin and still there is residual disease, whether adding capecitabine now will improve survival, because that data doesn't exist. So I'll stop here. I'll ask Dr. Gupta sir to summarize, or any other panelist who wants to contribute anything or anything from the audience.
So Prasad, I have nothing more to add. I completely agree with your conclusions. Just that, you know, I again want to emphasize that correlation of PCR with survival is there, but the correlation of delta in PCR with delta in survival hasn't been consistent.
Yes, sir.
That's what I always make the point, and somehow I'm unable to get it across. So delta in PCR correlating with delta in survival is what we are interested in. That hasn't been consistent. And yes, of course, you know, the data doesn't support, current data doesn't support PARP inhibition and immunotherapy. We hope that there will be data to support both these treatment options, but I'm not very hopeful about PARP, although I do think that immunotherapy might enter into our practice, at least in a subgroup of patients. So I would like to also thank Dr. Mansi for inviting me to this very nice panel.
Thank you, sir.
Thank you, everyone, for
Thank you, Dr.
interesting
Prasad.
participation. Yeah.
Thank you.
Bye.
So thank you for this amazing discussion. We do have the coordinator just messaged me saying that we have about 230 participants that are listening to us right now, and I would like to move on to the next session. And thank you, Dr. Pankaj Shasal. Sir, do you want to add anything? Sir, you are muted. Sir, you're muted.
I was just waiting to listen what more has come, because triple negative cancer has defeated me at many occasions. Thank you.
Thank you, sir.
Mansi, I just want to make an announcement to all the faculty. We have a 250 plus audience watching the live telecast.
Good.
Yes, sir. Thank you, sir. Sir, do you want to give your inputs? Actually,
no, I think this discussion is going on, and I think Dr. Vani Parmal will definitely going to address more local regional treatment after neoadjuvant therapy. So I should focus on that.
Yes, sir.
Thank you.
Thanks. So if I can call upon the screen our next chairperson, Dr. Shirish Alurkar. Alurkar, sir. Is he here?
Yeah. Yeah, Dr. Mansi. I'm here.
Sir, you're driving or sitting in the back seat?
No, the advantage. Yeah, so thanks Dr. Mansi, Dr. Vijay, and Dr. Ashish to give me this chance to chair this session. The advantage of attending these Zoom sessions is you can attend them on the move. Incidentally, I had been to the airport to pick up my daughter at the same time this session came up. Anyway, without further ado, we have two very interesting panel discussions and equally dynamic moderators. The first one is Dr. Vani Parmar, who will be addressing the issue of loco-regional disease after neoadjuvant therapy. So obviously she'll be talking what to do with the role of sentinel node biopsy, how to address the axilla, do PCS or an MRM if it is not planned initially. The second panel discussion is on the role of de-escalation in HER positive cases. And a lot of data now comes, especially with the APG trial initially, and now we have options of using the data on dual HER inhibitors. And this will be moderated by Dr. Vamsi Krishna, from medical oncologist from Chennai. So, Dr. Vani Parmar, if you're on line, you can take over.
Right. Thank you, Shirish, and thank you.
Vani, we all know that Shirish is an upwardly mobile medical oncologist.
Absolutely.
Rapidly. Vani,
I don't know. Okay, carry on. We are a little short of time, so you can curtail your panel by 5 minutes each. I think it will be good.
We'll try. Since most of the things have got discussed, so I'm quite happy with that. So as far as the panel is concerned, I welcome all. It's a very long panel, so I'm not going to be reading out everyone's names and most of them. And I think let me share the screen from one side. Yeah. So am I? Is my screen visible to all?
Yes.
Yes. Yes. So we have, in fact, my work has become a little easier because the discussion about path complete response in PCR and survival has really been dealt with very well, and Sudeep has brought forward a very important point, and I was going to bring it up later, but I'm glad that it got discussed. So we will eventually come to it as time goes. As far as let's see, doesn't seem to be moving. Give me all right. So we started off. The purpose of giving a neoadjuvant chemotherapy was primarily to treat subclinical clinical metastasis with the intent to improve survival, and that has been completely ruled out, as we have heard enough in the last panel itself. The actual outcome that has happened is actually a reduction in tumor burden in both breast and axillary lymph nodes, and has helped us to de-escalate breast and axillary node surgery, if at all anything. I don't think we have moved anywhere beyond this as it comes to neoadjuvant chemotherapy. Let's start off with an arbitrary case scenario, because I thought having some things there to kind of anchor ourselves is always easier when we take forward a discussion. So starting off with a 35-year-old young premenopausal lady, presenting with a 6-centimeter hard lump of 2 months duration in her left breast with multiple discrete axillary lymph nodes, imaging confirming a single lesion with no microcalcification. Her core biopsy showed an IDC grade 3 triple negative breast cancer. There were no distant metastases, no family history, and patient wanted to discuss the possibility of breast conservation. I've made this into a very suitable, ideal case where I'm sure every medical oncologist who's there will be thinking, what else will you do? You're going to give a chemo anyway, isn't it? Had I put the tumor at 2 centimeters, I'm sure the debate would have been much wider, asking that should you be giving neoadjuvant for a 2 centimeter and then operating because she's triple negative, or would you consider just doing an upfront surgery and going for adjuvant? I think that's where the whole controversy would come in. So this case scenario here is pretty clear. If I were to then ask that what are the essentials, my panel, let me start off with the medical oncologist. We have Rahul and Amit. So if one of you can comment on this. So what are the essentials in this kind of a scenario we are talking about? Want to
Yes,
do?
Madam, may I answer? Rahul here.
Yeah, Rahul, please.
Okay, so it's a T3 disease with nodes, multiple nodes are there. So we would like to rule out the metastasis first. I said practically most of the times we are doing PET scan. And if PET scan is not available because of COVID or other things, then CT thorax with a bone scan.
So as very clearly put, of course, what I was looking at is a metastatic workup doing an individual test versus a PET CT scan has become a different debate now, and majority of people are moving towards doing a PET CT, with its knowing fully well the nuances where a PET CT would probably bring out issues of other causes of nodal metastasis in the mediastinum, and they would cause a false positive. We are aware of all those discussions. So I'm not going to harp too much on the imaging bit and the details of it. But yes, I guess there will be a divided discussion which will happen on those who would be against a PET CT scan and those who would probably fight for it, but tooth and nail. So I'm not going to get that discussion again.
Yeah.
But
suppose if nodes would have been negative, then CT thorax would have been okay. But there are multiple nodes, triple negative breast cancer, 6 centimeter lesions. So I will be more inclined towards PET scan.
I'm not very sure about that answer, whether having nodes would definitely incline you towards doing a PET CT scan versus a CCT along with a bone scan as a routine imaging. I don't think it's the nodes which decide or the burden of disease. I guess just imaging to pick up distant disease, and you're talking about one test evaluating the whole body versus multiple individual tests, keeping in mind fully that there can be false positives in one of the tests. So I'm not getting into the debate of PET CT versus multiple tests here. But what we are specifically saying is we need imaging to rule out distant disease because this is a large tumor, and that's where we come down to deciding whether or not to do a further surgery once chemotherapy has been completed. I think that's where we are just leading to. Biopsy, whether you need to actually identify the site. So Veda, Vedant, any one of you can answer this. Tane, how would you go about identifying and doing a biopsy in this particular patient?
So please go ahead. Please go ahead.
Yeah.
Sir, please, you go ahead, sir.
Yeah, go ahead.
Vani, before biopsy, I think we haven't completed the imaging also. We haven't had a mammogram, which is very essential. And if the breasts are dense, then I would also like to do MR, although that's again a controversial issue, but I do, since the lady is keen for conservation. Biopsy, there is a lot of data for USG guided biopsy, but if a patient comes to me with a palpable lump which is uniform on imaging, ultrasound imaging, I don't hesitate to do a blind biopsy, but otherwise ultrasound guided biopsy.
All right. So maybe in a 35-year-old, the issue whether you need to add an MRI can always be brought in here, and I would not refute that because you would expect this to be a dense breast. It's a large tumor, clinically palpable. However, you do want to find out whether there is a multicentricity involved here, and there's why a 35-year-old you would use this test. But if she was a 55-year-old with a similar kind of a presentation, I may not.
Yeah, that's right.
Towards doing an MRI, because I know that the mammogram, which is a routine test that we're doing, would have clearly shown us that this is a single lesion. because you expect a fatty breast in that patient. And then the MRI may not help. As far as the ultrasound guided biopsy is concerned, Veda, would you want to comment? Would you be very happy?
Yeah. So because ultrasound guided biopsy has the added advantage, of course, she has multiple discrete lymph nodes, and if I want to sample the lymph nodes, I will do it.
You're not audible very clearly.
Okay.
What Veda is saying.
Can you hear me now?
Yeah, much better, much better.
So yeah, doing an ultrasound of the breast will help me because I can sample the axillary nodes at the same time.
All right, so you have a point there. You have a point there, definitely.
Yeah, and TNBC is more to be heterogeneous. Sometimes you have a cystic component, and suppose you have a solid cystic component, that will always help.
All right. So you have a point there that you want to pick up the ideal site for a biopsy, one. Secondly, you probably would like to do an ultrasound of the axilla and try to biopsy. These are the points in favor of an ultrasound. But I have a little concern, and I think the radiologist who's with us is Dr. Neha. Yeah, no, I'll come to the marker as well. I'll put that as the third point, but before that, so identifying the actual site. When you have a 6 centimeter tumor, I don't think an ultrasound is really required because you can feel the tumor and you can definitely hit the tumor and you will not make a mistake because the cores are taken in multiple directions. If you take a core, you're doing multiple cores in different directions and you will definitely get the representative sample there. The second point is if you're doing an ultrasound guided for a smaller tumor, this was a 6 centimeter, easy game. But if this was a 2 centimeter tumor and then because you can't feel it properly and you want to do an ultrasound guided, I have a major concern, and I'm sure the radiologist will also agree with me, that the ultrasound probe goes right on top of the tumor. The entry point of the biopsy would be probably from a lateral side. The core biopsy will definitely not mark the site of the primary. And you will end up with the marking on the breast, which does not correspond with the tumor. If you're putting a marker in, yes, that's good. But if you're not putting a marker in and using the core biopsy site, you're lost after the chemotherapy. And then the second debate would be in a 2 centimeter, why would you give chemo upfront? Why not do a surgery upfront? That's another debate, and we'll come to that in the next few minutes. All right. So as far as the ultrasound guided biopsy is concerned, Neha, do you want to make a comment on this?
Ma'am, definitely. As the histopathology is TNBC and Dr. Veda said that it will definitely give us the idea about the necrotic part and the solid part of the lesion. That is one. Within the center of the lesion. We can definitely go through the lateral approach, which is parallel to the chest wall and a safer also in case of breast intervention. And still we can go up to the center of the lesion and keep the marker in the center. Because ideally we do know that post chemotherapy there can be a heterogeneous response and the marker can get displaced, the clip marker can get displaced, and we have a problem after chemotherapy. So ideally that is not the problem whether we should go directly perpendicular or parallel. We routinely go parallel to the chest wall and we reach up to the center of, even though the path becomes a little longer, but still we go from we keep the probe parallel only.
Let me just interrupt you there. So we got the point, but what I was bringing out is that an ultrasound guided biopsy is probably only required in a small tumor where it is deep seated and you can't localize it by manually fixing the tumor. In all other situations, we don't need an ultrasound guided. We can fix the tumor by hand and go directly over it because you are using the core biopsy itself to mark the primary. In such situations, if you're doing a core from a different site, you always end up losing the orientation of where the tumor is. Everybody does not put a clip. Clip is definitely recommended. It's good to put in a clip, but then everybody does not put in a clip and a marker, and that's where you're lost when you're trying to treat the patient after chemotherapy. So that must be kept in mind. Doing a core is mandatory. Getting a tissue diagnosis and knowing the receptor status is required to know what chemotherapy. But if you don't know exactly where the tumor was, you will be lost. Is the extent of the tumor bed also to be marked? I would allow, let's see, any of the surgeons can answer. Tanay, you can take it, or Vedant, you want to answer that? Do you think the extent of bed?
Yes, ma'am. We just need to mark the center of the tumor. That can be done easily under guidance of USG. We don't need to mark the entire extent of the tumor as such.
Absolutely.
I would like the tumor to be marked in the center.
Vedant,
Preferably with a clip.
I agree.
Okay.
In fact, for such a big tumor, I would not even mark at the initial biopsy. I would wait for the response if the patient is following up nicely, and then mark it when it is maybe 2 centimeters or smaller.
Right. So that's another way of managing it as well, that if you have not marked it right in the beginning, you're following the patient up, patient is taking chemo with you, you can actually follow the tumor size, and if it is shrinking down, and you can then put in the clip at a much later stage. Even that is a practical possibility if you have clip as one of your access modalities that you can offer to the patient. Agreed. The axillary workup was mentioned when we talked about ultrasound. So Veda did say that if you want doing an ultrasound, I would like to do an ultrasound of axilla and also identify the node and then decide whether or not I'm going to put a clip in there as well, right, Veda?
Yes.
So that's one point that was brought in. But it's not, again, a routine standard of care that everybody does an ultrasound to put a clip in. Yes, you can do an ultrasound if there was no node felt, but a large tumor. Now, in this situation, this patient had axillary nodes. If she did not have, she had a 6 centimeter tumor, maybe I would just check in just to check whether there was a node there or not. Now, we're going to come to that much later as to how do you treat them differently if they have a node negative or a node positive. So as I sum it up here, triple test, definitely an important thing. Mammography to rule out other tumors, microcalcifications, etc. MRI, again, MRI just to get a negative margin is not a routine thing. I think only indicated when there is a dense breast or if you are not able to assess well on the first imaging with mammogram. A core biopsy to understand the receptor status and to plan the chemotherapy. And once planned for chemotherapy, marking the primary is essential. And we've said that a radiopaque marker or a clip, a core biopsy incision to mark it, or a pre-treatment tattooing of the margin of the palpable tumor area. Again, this pre-treatment tattooing is one option that's been mentioned, but I'm against this completely because we are not, the whole purpose of giving neoadjuvant chemotherapy to downsize a tumor is lost the minute you talk about tattooing of margins of palpable tumor area, because you are not trying to, cosmetically make some mark on the breast as if, that's how you're going to mark the tumor. Secondly, it's never going to help you later on because you're not looking at taking the whole tumor bed out. You're only probably going to do radiation there, but you're not going to do a tumor bed excision. You're going to do a residual tumor excision. So the last point has been mentioned here only to refute saying do not do this. All right. So this patient received neoadjuvant 4 cycles of AC. She was triple negative. In view of good response, completed paclitaxel also 12 weekly and reassessed for response and planned for surgery. I am not getting into the debate of what chemo I should have given because we had the previous session, we talked about what chemo, whether to give platinum or not, what is the benefit, etc. But what I'm really more interested now is understanding what do you do once you have given chemo and you have a response. So we are going to move ahead on response to neoadjuvant chemotherapy. How do you assess? So any one of you can take these on. Let me have the surgeons answering. How do you assess response to chemotherapy? Veda.
So, for response assessment to chemotherapy, MRI has an edge over routine mammogram or ultrasound. So I would prefer, especially in a young patient, an MRI of the breast to see what the response is.
Vedant, you want to comment on that as a routine?
Yeah, so if I have already done one MR, the tumor is nicely responding on clinical palpation as well as on ultrasound, I would not do MR again.
All right, we have another viewpoint. Third viewpoint. Tanay,
I think,
ma'am, for a young lady, it is different. I mean, if MRI was considered pre-NSCT setting, then I would definitely follow it up with MRI. But otherwise, routine sonomammogram would suffice, and I'll add up. Interval examination while she is undergoing chemotherapy. So after 4 cycles, I would like to reassess. And if clinically response is not good, then I would consider doing a sonomammogram again after 4 cycles of.
So let me kind of sum up the 3 points that you gave. We said that if you have done an MRI in the beginning and you have assessed it, maybe you use the same tool to reassess later. But if I have an ultrasound and a mammogram and an MRI which confirm that what I found on clinical triple test, remember, Remember, clinical examination was confirmed on a mammogram as a single lesion, 6 centimeter. You've seen that there's nothing else. I don't think I would now jump to an MRI later to reassess and relook at the rest of the breast because your clinical correlation has already happened in the first test. You may not need to escalate your imaging later on just to evaluate and decide what you want to do with this patient. If she's clinically responding from 6 to 2, you will accept it. So then I will come to the pathologist too as to what are the kind of responses, but let's just hold it there. So if you have a clinical correlation, you have a response, you may not want to intensify your imaging later on. Agreed on that, most of the panel? So
yes, I agree.
Again, that is more better, or it is the biology that defines better? Now, this is kind of referring back to when you're looking at response to chemo. Do you want to just keep on giving more chemotherapy to get the best response? Or do you think it's the biology which is going to define anyway? So it doesn't matter. If she's responded with the standard 4, or do you need to go from 4 to 8 and then do a surgery because she will do better? So that has already been touched upon by Sudeep last, that PCR has never really translated, improving PCR or the delta in PCR, translating into a delta and survival is not proven. So is more better, or is it the biology that defines? Anyone can be.
Ma'am, if we see the, if we divide the breast cancer into early breast cancer or locally advanced. So if it's, we are talking of early breast cancer like T3, T4, up to T3 region, when there is no locally advanced, we are giving chemotherapy for the response. Then the biology is important because we have to give neoadjuvant in at least triple negative cancers, not in ER/PR positive.
So I will come back on that. Now, do you think it's mandatory for all triple negatives to get chemotherapy upfront?
Ma'am, see, it depends on the situation, the patient. I have to discuss with the patient if they are ready for the change of the treatment after therapy. Like, we can divide breast cancers into early breast cancers into 3 types. One is hormone positive, HER2 positive, and triple negative.
My question is very focused. Why do you need to give a chemotherapy upfront for an upfront operable? She's 6 centimeters, I agree. And come back again. If she was an arbitrary 2 centimeter tumor, triple negative, why would you be giving her chemotherapy upfront? You have no benefit in survival that has been proven by giving her.
Especially in triple negative breast cancer, young patient, if we are giving adjuvant chemotherapy, we are not knowing whether it has worked or not. We have a surrogate marker of PCR in at least triple negative breast cancer. So in triple negative breast cancer, with all data coming up, NCCN guidelines also saying up, other guidelines also saying up, I would like to give neoadjuvant chemotherapy and add capecitabine if there is no pathological CR in a triple negative breast cancer.
Challenge you with the second question. If you think that it is the PCR that you're looking at, we know that the smaller the tumor is, always there is a PCR, because the 2 centimeter would definitely respond much better than an 8 centimeter tumor. So tumor itself is a surrogate marker. If you look at tumor size itself, the smaller the tumor, better the response. And this is known in predictors of response. So if you have a 2 centimeter, it's going to disappear anyway. Why you would not be requiring to give her capecitabine. But if you have a 2 centimeter and then you have operated, if she is clinically having one node positive there, not multiple matted nodes, not at LABC, I'm talking about a
early breast cancer. Operable early breast cancer.
You're talking about is residual in a locally advanced or large tumors where there is residual disease. That is where capecitabine has worked in Createx. They have not looked at early breast cancers 2 centimeter and 3 centimeter. So I don't think there is a role here of doing a neoadjuvant standard chemotherapy for all patients who are triple negative. All patients who are HER2 positive have to receive a neoadjuvant chemotherapy. I think the evidence to that is not strong enough. Anyone who wants to answer on that? Veda, do you want to answer? Veda?
Yeah, I agree. I agree with you. For a 2 centimeter node negative, I would operate first. Rest all of them would go for neoadjuvant. Yes, node positive goes for neoadjuvant, but 2 centimeter and less would be a bit too much to give neoadjuvant.
Amit, I'm going to challenge it because if I ask most oncologists to answer this, they'll tell me no, we have to give her chemotherapy with no evidence that it is ever translated into. So the minute you give chemo, there is a different variable response that you get. Those who have actually a kind of response, and then there are those who come back with the honeycomb regression where there is area which is much larger. So the tumor bed itself probably doesn't fill. So when you have a response which is actually tumor responded, but it is a honeycomb response, you don't find clinical in evidence of response which is so great. In such a situation, of course, you will end up with a tumor bed excision which is more or less equivalent to what you had started off with. So anybody wants to comment on, a triple negative, no DCIS? Do you think you will have a response of this kind of a honeycomb response, or is there a correlation between a honeycomb regression and actually a multicentricity or multifocality within the tumor, defined by either DCIS, or if the tumor did start out as multiple tumors and then they have now started thinking they have come out as separately as variable tumors. So, Dr. Shubhada, do you want to take that on?
Can you repeat the question again, please?
So is the variability in pattern of tumor response correlating with presence or absence of DCIS?
Oh, yeah. Yes. If the patient has extensive DCIS, then the chances that she would have this honeycomb pattern of response would be more, because between IDC and DCIS is resistant to the chemo. DCIS high grade doesn't vanish with the chemo. So it correlates with the extent of DCIS.
Absolutely. So if you start off with the tumor, and this is a huge debate in LABC, should you go for a tumor bed excision or should it be only the residual tumor? I think where you have a core biopsy upfront which has shown a tumor with DCIS non-calcific, or you have an imaging which has picked up multiple calcification within the tumor, neoadjuvant chemo would be mandated if you go to LABC. But expecting them to be downsized and de-escalate surgery down to breast conservation, you can probably, right in the beginning, will never have a de-escalation in size. I think if you have no DCIS present right in the beginning, you have a single lesion, large tumor, and core biopsy has not shown DCIS, such a patient, you expect them to downsize and come down to a size where they will be feasible for a breast conservation. So there are certain things that you can reassess and know in a particular patient whether they will respond or not. Obviously, biology does play a very important role, and we have this evidence clear enough that HER2 positives and triple negatives have a higher PCRs, in spite of knowing that these are actually bad biology tumors, but they respond much better. So this is where the PCR itself does not really stand up between biologies, but within biology, a PCR does better than not. This is a pre-chemo mammo of the same patient. You can see a large single tumor, responded well to her chemotherapy, it has come down to a very small size, it is de-escalated and appears feasible to offer breast conservation. In contrast is another patient, this is not the same, is another patient with a single large tumor. You can't see any microcalcification. It appears to be a large tumor, multiple nodes, chemo given, and then you can see very clearly, I'm not sure if the screen shows, a tumor has shrunk, but there is microcalcification extending in a large area. So this is where you have a problem of tumor bed, the pattern of response being a single lesion versus multiple lesions. All right, so you have a good response, patient responded well. So again, we come down to now breast conservation versus mastectomy. So treatment of primary we'll discuss, followed by treatment of axilla. In the primary, breast conservation versus mastectomy. Anyone can take that. So Veda, you want to take the question, please?
Yeah, so one consideration is, if she's keen for breast conservation, there is no contraindication, provided her genetic status is okay with it. And post NACP, if it's a good concentric response, you can go around and do a breast conservation.
Right, so you brought in a genetic component now. Vedant, do you want to take that? Do you think if they should a BRCA positive?
So there is no contraindication even for BRCA positive.
No contraindication, but that's a concern.
But yes, actually I wanted to say that during the workup also that we need to have genetic counseling and possibly testing done for her because of her age as well as triple negative status. So if it is positive, yes, we have to discuss with her the options. But now that she has had a disease, doing bilateral mastectomy would not really affect her survival. It would affect only the second primaries from appearing. And breast conservation definitely is not a contraindication.
Absolutely. So it's not that if she was a BRCA positive, I would not discuss the option of breast conservation. You have to assess individually each patient to understand what is the level of anxiety, what is their concern, what is the BRCA which is mutated, and then take it forward from there and discuss whether she is keen on conservation versus mastectomy. Mastectomy is not mandated in a patient who's BRCA positive, and that should be clearly understood that we can offer them breast conservation safely.
Just one point to be added, madam, for BRCA positive patients.
Yes.
So if we are thinking of offering them mastectomy rather than BCS, just by the virtue of them being BRCA positive,
no,
practically these patients are, likely to develop mets of the primary disease first rather than recurrence. So metastasis from the primary disease would be earlier compared to local recurrence.
Probably.
So it is no harm in offering them BCS.
Agree. So everybody agrees on that breast conservation is safely offered in these patients. Where is breast conservation clearly contraindicated? Probably if you have had a patchy response, yes. If you had
so for this tumor, even with a patchy response, you can have a wider excision and a LD fill there.
Oncoplasty has actually now brought down the level where you need to do a mastectomy chemo for most of the patients. But what is the level of evidence on this? We still probably are stuck at level 3 evidence. We don't have a level 1 evidence of safety of one against the other. We know safety is available, but whether it impacts negatively on outcomes is really not known. An outcome impact requires a prospective randomized trial, and we have one running right now in TMC, where we are looking at patients receiving chemo, downsizing, responded, and then being randomized between breast conservation and mastectomy. When I had written my paper in 2006, I had put it up as it would be difficult to randomize, but it's surprising that with such a large number that is required, we are actually having patients agreeing to it and agreeing to be part of a trial where they would randomize for breast conservation versus mastectomy. And it's interesting how the thought process of women actually changed. And we should move with time, and this is where we are.
Dr. Vani, may I ask the question?
Yes.
When you excise the specimen for breast conservation surgery, will you send it for a specimen mammogram just to make sure that all the microcalcification that showed up has been removed?
All right. So since you asked me the question, I'll not put this to panel. I will answer it. So if she had extensive microcal in the which was probably noticed even in before chemo, and post chemo also had microcalcification within the tumor, I would excise it. Whatever the repair would be, whether I do oncoplasty or an LD or whatever, the easiest way of knowing that the margin is clear is send the specimen for a mammogram, because you will get a clear imaging of how far from the margin is the microcal. I would not do a frozen section of the margin or try to get a frozen section to assess whether DCIS is present in the margin, because that's really, I think the pathologist will agree that it is completely going to be a waste of time and energy trying to freeze all those margins to understand if DCIS is still there. So the best kind of a surrogate marker is just send that to the specimen mammogram, get an imaging there, and know that you have got the tumor out. I agree with you. Now I'll bring in another point. What if the tumor had completely disappeared? No microcalcification, no tumor there. What about no surgery if there is a radiological and clinical PAT CR?
Surgery has to be done. As of today, as of today, surgery needs to be done.
And the evidence towards that is?
Because there is a lot of residual tumor when you excise, and there is actually a study also which has looked at guided biopsies, and they found residual tumors there.
Absolutely. No surgery, really not something that is accepted. Yes, Tanay, you want to say something?
Yeah, many studies, people have tried to explore this fantasy, but none of the studies, barring one, has succeeded to achieve a false, there is no substitute for PCR.
Right.
So, but there's one, the MD Anderson, but what they've been trying to do is they mark the tumor bed and they do at least a vacuum assisted biopsy, multiple core biopsies.
So there is a PCR. We'll come to that. So in fact,
one micro study is also there. They are trying to explore whether, getting an MRI after the end of neoadjuvant chemo, and if there is clinical complete response, then they try and do a vacuum assisted biopsy or a mammography assisted biopsy or USG assisted biopsy. But still, they have failed to achieve a false negative rate of less than 10%, I guess.
Okay, so essentially, whatever it is, everybody is trying to get the surgeon out of the practice as soon as possible, get them off so that there is no surgery possible, no surgeon's role available there for that patient, and only a medical oncologist and a radiation oncologist treats such patients. But I guess that will take a little time, and we are going to absolutely look at. So the EBC-GCG meta-analysis actually came up with this data where the no surgery bit. The no surgery arm actually had a greater impact of local recurrences. The survival, of course, we know for sure in the data analysis that we had no benefit either in distant recurrences, breast cancer death, or death from any cause. Whereas if you see the local recurrences where surgery was not being done, it was very high. And in fact, there was another important finding that in those who had received chemotherapy and then had surgery, mind you, that surgery was not defined as breast conservation or mastectomy. But post-chemotherapy surgery done, there was an increased local recurrence by 5.5%. And this was for NACT versus adjuvant. And unfortunately, it has been translated into, when you give NACT and you do breast conservation versus mastectomy, the comparison was neoadjuvant chemotherapy versus adjuvant chemotherapy. The rate of recurrences was up by 5.5%, which includes breast conservations and mastectomy. And a 50-year outcome, the relative risk of recurrence was 1.37-fold, that is much higher, and which is clinically significant. So interesting, if you look out in this subset where there was no surgery done, it was the no surgery arm which contributed maximally to the higher local recurrences in breast conservation. So the conservations done with no surgery done was where there was a higher local recurrence. So that was actually 33.7% for NACT. So in this whole thing, if you realize that it is only surgery versus no surgery, again, neoadjuvant versus adjuvant that got compared, this was a retrospective data which had been put together. It's still not the answer to understanding whether or not doing a surgery after neoadjuvant chemotherapy has higher local recurrences. All right. So the
Vani ma'am, I'm sorry, we'll have to kind of
wrap up.
Done. Okay, just study participants who achieved an image-guided biopsy and then PCR are the ones who are being prospectively randomized. This is the ongoing study that we just referred. Now, quickly running over to the post-NACT axilla management. So, management of axilla, I can define it into two subsets. Those who are upfront are either, so I'm putting it as early breast cancers as well as locally advanced. So, early breast cancers means those who are smaller tumors, node negative, you're giving them for breast tumor ratio being not suitable for conservation, downsizing and downsizing the tumor as well as the axilla, and those who are N0 upfront versus those who are node positive in the beginning and you're giving chemotherapy to such patients. So I'm going to skip these because most of these have got discussed in the auxiliary management, but we do know that within the response to chemotherapy, biopsy does play a very important role even in the axilla. And the feasibility of doing a sentinel lymph node biopsy actually goes up even in the larger, higher, more aggressive tumors of HER2 positives and triple negatives, because the response is much higher in these patients. So going by the chemotherapy status of axilla being positive probably is not the right way of deciding whether or not the patient is eligible. So eligibility is one, and second is, should you do and should you plan based upon these, the prediction of axilla for the imaging. So what is the imaging for axilla? We've discussed that. Ultrasound and MRI per se are not helpful post neoadjuvant chemotherapy in reducing the FNR, but then an ultrasound along with clipping of the involved node in the post chemotherapy would probably help us to identify the correct lymph node and brings down the false negative rate. The clipped node not being a sentinel node is seen in more than 20% cases. And if the clipped node is retrieved and more than up to 3 or more lymph nodes are retrieved, the false negative rate does come down. So going by the data that's available. So if patient was node negative, how would you take this forward in the post chemotherapy status on the axillary management? Veda.
So yeah, if the patient was node negative upfront and we're doing breast conservation after NACT, so there is an option for doing sentinel lymph node. Because in node negative status, sentinel node is more preferable. The FNR is much lower, and the standard NCCN guideline says that you should consider SLNB in all node negative even after NACT.
Right. So in a node negative, would you want to do a SNB before chemo, or would you like to do after?
So there are many schools of thought. Some of them do it institutional. Some institutions do it pre-chemotherapy, but I would prefer to do it post-chemo, because again that will actually doing it pre-chemo will be 2 surgeries, and there will be delay in initiating chemotherapy. Some practical and logistic considerations to be worked on.
All right. So if you had a pre-chemotherapy, if you had gone ahead and done a sentinel node, you got a positive, and then you gave chemo, would you then go ahead and do a clearance?
So these are some technical challenges. So I would prefer post-chemotherapy.
So you believe that not knowing is better than knowing? Is that what the answer is? Vedant?
No.
Yeah,
First,
because then you give higher chance of conserving axilla to those who are N0 on imaging, but actually maybe having micrometastatic disease. This is one. The other issue is if you do sentinel node, it is positive, responds very well, and you want to do sentinel node again, it has a very low identification rate and very high false negative rate.
Absolutely.
So it's better to do it after NACT.
Yes.
One practical solution to this. May I please, madam?
Yes, please, Tanay.
Yeah. So one practical solution to this kind of problem is if we have done a pre-chemo sentinel node biopsy, it has turned out to be positive, and now the axilla has responded very well. So rather than considering sentinel node biopsy again, we can just go ahead and do a low axillary clearance, and that would otherwise downstate the axillary surgery, and at the same time will provide some safety also.
So effectively, we agree that if she was a node negative or a lower nodal burden in the beginning, we've given chemo, and then after that, it's feasible to do. Yes, and low axillary sampling does have evidence now in a large number of patients that the false negative rate is actually below 10%. And is definitely, if you can accept it in the upfront status, you can accept this even in the post-chemo. But it always comes with a little pinch of salt, because you don't really have an outcome data on these. You need to have a survival being not impacted by doing such a thing in a larger, more aggressive tumor before saying that, yes, we can go ahead and safely do a low axillary sampling and stop at that. It's feasible, whoever, it is definitely acceptable, but I don't think we are yet at that level. Now, if you move on to the situation where you have, supposing post-chemotherapy and you have picked up, say, macrometastasis, we all agree that we do an axillary lymph node dissection in this situation. What if there was a micrometastasis after chemotherapy in a patient who was node positive beginning and you've given chemo?
We have to dissect axilla.
Exactly.
Again, axillary dissection, madam.
Is everybody agreeing on that?
Yes.
Absolutely. As far as isolated tumor cells, there is not sufficient data on that. So again,
Dr. Vani, can this be the last slide, please?
Well, we're nearly there. Yes. Let me skip
Organizers are also telling me to.
Yes. So in N0, we have agreed acceptable false negative rates. In the other Gania trial is also similar to that. I'm going to skip that as well. In node positives after chemo, we have not had evidence of safety. False negative rate is being high with most of the studies. And it is in this situation that they've said dual tracer and removal of more than 3 lymph nodes brings the FNR down to 10. And that's where I think the LAS really, low axillary sampling, has kind of got a point above all these trials, because it anyway picks up at least 4 nodes, and then we have a data which clearly says that if you have 3 or more nodes in the LAS specimen, which is done very easily, we are able to get a negative false negative rate, which is highly acceptable. This is the data that we refer to, that the false negative rate seems to be high in these patients when you do sentinel node. All right, I think we are more or less, we have discussed most of these points. The meta-analysis in N1 pre-NACT, we know that in these patients, the false negative rate is still very high, and LAS, as I've said, is definitely. So this is the last concluding one. Sentinel node biopsy after neoadjuvant chemotherapy, a 5-year follow-up with clinically node negative, node positive before treatment. We have evidence in the early breast cancer, but after neoadjuvant, we do not have. This is, okay, sorry. There's a long-term, there's only one actually paper which has come out with long-term data of SNB done in a post-neoadjuvant axilla by Viviana Galimberti from European Institute of Oncology. And they have clearly said that the SNB is acceptable in CN1 and 2 who become N0 after neoadjuvant. Sample size is small, it's a retrospective data. This is the only data available. But again, these are patients who are actually small tumors, T1 to 4, N0, N1, N2, where majority were actually N0 and N1. So these are not really a data that we can translate into our data set, and we would definitely look at our own data for developing, for finding out whether or not we want to accept this kind of a intervention post-chemotherapy. These are the 2 radiotherapy trials. So radiation oncologists, I'm sorry, I didn't have much for you, but yes, there are 2 trials, if you want to talk about it, which are testing the role of radiation versus surgery in these patients. So there is a random assignment of doing the radiation versus not radiating in these patients. So this is two trials. The alliance actually looks at completion followed by nodal RT versus only nodal RT, no surgery. So there is a questioning of whether you can do away with surgery in these patients, and I think these are still to be completed before we get any data on them. So I guess that's the end of our panel discussion. We have kind of agreed to agree on most of the points and agree to disagree on the fact that we are ready there to apply post-neoadjuvant no surgery as a mode of treatment for patients. We needed to really wait for data to come up before we offer them no surgery for axilla. Currently, I think if you have a positive node, macro or micrometastasis, we go ahead with the clearance. As far as triple negatives and HER2 positives, they have a complete response. We can offer them, but we need a follow-up data with survival before we accept, post neoadjuvant chemotherapy, no negative axilla to be conserved with no surgery. I guess we can stop there, and thank you very much for the whole panel. I'm sorry for overshooting the time by a little while. It's a topic which can go on for another 15 minutes because everybody wants to have an opinion in this. So Mansi, thank you very much for being patient. So I thank the organizers for having invited us all over for this.
Thank you.
Thank you. Thank you.
Dr. Vani, of course, is one of the proponents of lower axillary sampling and has published a lot of work on lower axillary sampling. Mansi, we can now move on to the next talk.
Yes, if Dr. Aruka sir,
yeah,
if you have
so
any
I would
comments.
like to invite Dr. Vamsi Krishna. I think we'll go ahead with the
Okay.
maybe have discussion. So I'll like to invite Dr. Vamsi Krishna. Without further ado, please call your panelists and we'll start.
Yeah. Am I audible, please?
Yes. Yes.
Yeah, thank you. Good evening. So I would like to call the panelists, the radiologist, Dr. Diva Shah, radiation oncologist, Dr. Nidhi, surgical oncologist, Dr. Arnab, and Dr. Anagha Zopa. I think I have just seen you both entering the meeting room. And medical oncologist, Dr. Vishwanath, Dr. Preetham, and Dr. Mansi. So thanks to the organizers for giving me a chance to talk on this interesting topic. Now it is 6:27 by my phone, and I will switch off exactly at 6:57 because I have been told to do it in 30 minutes. Right. When we talk of de-escalation in HER2 positive breast cancer, can we go back now? What do we mean by de-escalation? It means basically trying to reduce the treatment that we do normally. So the normal treatment in breast cancer for a HER2 positive would be surgery, chemotherapy, which includes anthracycline taxane, trastuzumab, and then radiotherapy, and followed by endocrine if needed. So let's see where we can de-escalate from this model, right? Now, this is a case, a 65-year-old lady, incidentally noted lump in the breast, clinically 2 centimeter, BI-RADS 4, a biopsy suggestive of IDC grade 2. So if I can start with Dr. Diva, radiologically, how can we evaluate the axilla? The breast is fine. We know it is 2 centimeter. How do you evaluate the axilla at this point? Dr. Diva, are you there? Okay. While she comes online, could I request Dr. Arnab to just come in because you're a surgeon? You would be seeing these patients pretty early. Dr. Arnab? Okay, Dr. Anagha?
Hello.
Hi.
Yeah.
So radiologically,
yeah.
Understanding that we have already had a triple assessment done, I would have the data from the ultrasound of the axilla as well as the mammography of the axilla.
Is this okay?
Yeah.
Beyond that?
Beyond that, I would definitely like a cytological.
Hello.
If there is any lymph node which is looking suspicious, biopsy, a core biopsy, ultrasound guided core biopsy, would definitely be the best way to.
So is this a routine practice? Because honestly, in most cases, we don't see this. Do you do a biopsy of the breast as well as the axilla in all cases?
Not in all cases, but in those cases where I need to ascertain if the axilla is clinically negative before I put the patient on NACT, especially in the the bad prognostic biologists, I definitely
fine. So it basically doing an ultrasound alone. You don't want a CT scan or a PET CT scan at this point. No. Okay, Dr. Arnab, if you have joined us, I think I heard someone joining. Yeah. Please.
Am I audible now?
Yes, you're audible. You're very much audible.
Yeah. Yes. Sorry, what's the question for me?
So the question was for a patient who is a small lump in the breast, 2 centimeter, clinically node negative, how do you evaluate the axilla? Do you at all evaluate it or is it needed?
Apart from clinical examination, obviously, I do what my previous faculty has said. I will do the ultrasound of the axilla.
All right.
If there's a suspicious node, I get a full biopsy on that as well.
Perfect. Next
but
slide,
I do
please.
We don't do it routinely. You know, it's only the patient who is going to come to. Pardon? Yeah.
Perfect. Okay. So to the surgical oncologist again, do you do a ER/PR HER2/neu pre-op in every case?
Yes, I do.
Every case, 1 centimeter, 2 centimeter, every case. Perfect. Dr. Arnab, what's your take on this? I think I cannot hear you. I think you have muted yourself,
Yes,
sir. You
have. You will do it.
You will
definitely do it unless the lump is very Can small.
you hear me?
Yes.
I think you have logged on from 2 devices, sir. So it's kind of echoing.
Exactly. I think I'm
now it's
having problem with the net. So I've got my mobile and the laptop on. But I have problem with the net. I've got my mobile and my laptop on. I'll prefer to use.
Okay, I think you're breaking. Dr. Vishwanath, as a medical oncologist, how often do you see these being done or pre-op? Because honestly, I'd hardly see this getting done pre-op.
Yeah, I agree with you, Dr. Vamsi, but generally in this kind of situation, I would definitely get an ER/PR HER2 status.
Pre-op, I think perfect. So again, for the teaching purpose, for the students who are watching, please get it done pre-op. It helps you, right? Okay. So is the planning done for a MRM versus BCS in an MDT, or is it a general discussion taken at the surgeon's level? Dr. Nagha.
So the discussion or the decision regarding a MRM versus BCS is usually a decision which is taken between myself and my patients after a MDT has been done and after they've already seen at least a medical oncologist.
Okay. The reason I keep asking this, or we have this discussion so many times, is basically the radiation. At least in my place, the radiation oncologist gets a bit miffed that a BCS has been done and they have never seen the patient prior to that. So Dr. Nidhi, if I can get in here, how do you really decide your post-BCS volumes? Is it easy to do that, or how do you get to do that?
We have an MDT prior to the surgical decision, and that involves all the 3 members of the team. Okay. And in our pre-surgery notes, the detailing is done considering the location and all the things that are mentioned on the case file. And post-surgery, 3 factors are taken into account. Number 1, our own clinical notes. Number 2, the imaging. And number 3, the post-op seroma.
So pre-op imaging, which one do you want? Because we just heard that's a small tumor. We would just end with a mammogram. You don't do anything else. Is that sufficient?
So that is good enough. That is good. That is
sufficient. Excellent. Yes. Excellent. PET CT scan quickly. Dr. Anagha said no. Dr. Arnab, PET CT scan in an early breast cancer. We are not talking about those big no. No. Okay. Dr. Nidhi?
No, it is not required.
Not required. Dr. Vishwanath? Medical oncologists love PET scans.
Yeah, in our institution, we are generally going with PET scans.
Even for this kind of a patient with a 2 centimeter tumor?
Yeah, generally we are going ahead with PET scan in our institution.
Very good. Next slide. So the reason I'm just skipping it because these are all discussed. Now, this patient had a MRM for whatever good reason. Histopathology showed an IDC grade 2, size of 1.7 centimeter. All 4 sentinel nodes were negative. ER/PR strongly positive, HER2/neu triple positive. So T1, C, N0, M0. Next slide. So for my medical oncologist, starting with Dr. Mansi, is there any cutoff where you would like to start using anti-HER2 therapy?
So, I mean, normally less than 0.5 centimeters, I usually don't favor anti-trastuzumab. But after that, yes.
Would the ER/PR change your decision? Or it's in both the cases?
In both cases.
Both cases. Dr. Preetham, if you're there, any difference in opinion, or would you agree with this? Dr. Preetham, are you there? Okay, Dr.
Hello.
Vishwanath.
Yeah, I'm audible.
Yeah. Preetham. Yes.
Sorry. So, as Dr. Mansi rightly said, more than 0.5 centimeter. 0.3 to 0.5 is a little bit concerning. There's a lot of debate about it. But yes, definitely more than 0.5 centimeter. Yeah.
Okay, very good. Next slide, please. So this is something which is pretty much standard by now. NCCN, for want of a better thing or just for want of one of the guidelines, says that if you have ER/PR positive, less than 0.5 centimeter N0, consider, but it's category 2B. So practically, I don't think anyone does. 0.6 to 1 centimeter is a little bit controversial. If people do give, some people don't. It's a bit controversial. Next slide. When it comes to hormone receptor negative, there is not that much confusion. There, everyone above 0.5 would probably be given chemotherapy and trastuzumab. Next slide. Next one. Next one. Yeah. Next one again. Next. Yeah. So this is my first de-escalation. First, we establish where anti-HER2 therapy is not given, and there it is definitely in tumors less than 5 centimeters. More than 0.5, HR negative, definitely you give. 0.5 to 1, my conclusion, sometimes we do omit, especially elderly, very strong HR positive, we might omit it, but yes, you are fully okay to give it in that case. Next slide. So starting with my medical oncologist here, what is the optimum therapy, Dr. Vishwanath? TH for 12 weeks, TCH or AC followed by TH. Remember, I started by saying AC, TH is standard. So this is a kind of a de-escalation, TH or TCH.
So this one is a T1C N0 M0, very early stage breast cancer, which is HER2 positive, and ERPR also positive. I would go with the APT trial, the updated analysis of weekly paclitaxel with trastuzumab followed by trastuzumab to complete 1 year has shown wonderful results. The updated analysis has also shown wonderful results. So I would just stick to that.
Okay, Dr. Preetham, you know, we are accused of looking for data. This is a phase 1 it's a single arm study. You don't have a comparator to say that actually APT is better, but still there's a lot of acceptance of this protocol. Would you agree with this protocol or would you want to go with the TCH?
No, I think TH followed by 1 year of transfer maintenance is pretty well enough because patient's ERPR positive. Now if the patient would have been ERPR negative, then we would have considered probably TCH or ECTH. Yeah.
So the app trial did include the ERPR negative as well. They had around 30% ERPR negative in that study. Would you still prefer TCH?
In ERPR negative, I think we should go for TCH. Yeah.
Okay, Dr. Mansi, do you agree? What is your practice?
So I think for the APT trial that we are discussing, quite a few, almost 2/3 of the patients were hormone positive.
Yeah, around 30% were negative, yes.
30% were negative. But I think I still like the data from the APT7 trial because I think there was another study like the ATTEMPT trial which looked at stage 1.
I will come to that, yes. So yes,
I think we have more data just than the APT7.
So do you agree with the ATTEMPT study? Do you agree with the ATTEMPT?
Yes.
So you would want to give TDM1 as well?
No. I agree with the ATTEMPT in the sense that paclitaxel has a good outcome. I want to give TDM1.
Very good. So if I can just go to the next slide. So this is the APT trial, and it is pretty unique for medical oncologists across the board to agree on anything without fighting. And this is actually not just me who is saying it. There was an ESMO consensus statement where they had a lot of people involved, and 90% kind of agreed with this. So where you have a tumor size less than 3 centimeter, completely dissected micromets only in one lymph node. This was an addition later, basically N0. Patients receiving pacli trastuzumab for 12 cycles, followed by trastuzumab for 1 year. Most of the patients in this study were actually less than T1C. Only 9 patients were more than 2 centimeters. So this was something that is standard now across trials. Next slide. So this is the EFS when they showed for HR negative, as Dr. Preetham was saying. As you went on, there was a slight difference. And this difference actually did come down to around 3% over 7 years. But the numbers are not too big. So we don't know how significant that is. But there is some tendency, looks like, that in HR negative, this may not be appropriate completely. Next slide. This was the ATTEMPT study that Dr. Mansi was talking about, where instead of giving any chemotherapy, you just gave TDM1. Now, you can call TDM1 a chemo as well because it does have the chemo component, but by and large, this was an attempt. Next slide. They tried to look at co-primary endpoints, whether there was a benefit in terms of toxicity as well as in terms of benefit in the survival. Next slide. So population was more or less similar to the APT study. TDM1 numerically did a little bit better, but next slide. Then they looked at the overall co-primary endpoint of toxicity. That did not show any benefit. And so ATTEMPT is a negative trial statistically. And frankly, it was not really much better. So I wouldn't put TDM1 right now in this category. Next slide. So de-escalation 2, 12 weeks of TH for T1 N0 and T2 up to 3 centimeter. Now, this is a mistake from my side. I apologize. It's actually saying that most patients in the trial were above 50 years of age. That's how it should have read. This is my mistake. So in younger patients, less than 50, HR negative, you need to discuss with your patients. As of now, only trastuzumab, no TDM1, no pertuzumab in this group. Next slide.
Only one point to answer.
Yes, Dr.
Yeah.
Tell me.
So in ABTRAL, if you see more than 2 centimeter, the number of patients were very
9
few.
patients. Yes,
yeah,
9
only
patients
9
only.
patients.
So we don't really, that's what I said.
Yeah.
T2 you would probably discuss with the patient.
Yeah.
Absolutely. Right. Case 2, a 63-year-old lady, palpable lump, 2 centimeter, node negative, biopsy IDC, ERPR negative, HER2 positive. She undergoes an MRM. Let's see, our surgeons are not as good as Dr. Anaga. They did not discuss in a MDT and they decided we'll go ahead with the surgery. Patient underwent MRM, pretty common scenario for all of us. Grade 3, 2.6 centimeter, 1/5 lymph node positive. So Dr. Anaga, if I can just get back to you, quick question. Would you do a completion axillary lymph node if you have 1 node positive?
Absolutely.
Absolutely. You are not following the ECHO-Z or Amoros?
No, especially I would rather look at the tumor biology, which I already have preoperatively, and then take my call.
So that's one more reason for all the students that please get a tumor biology done upfront. It helps you decide later on. If this was a ERPR positive, would you have done the same, or would you still have thought of doing leaving the nodes?
I would still have thought of
probably, absolutely. Absolutely. Standard of care, that's what we most of us do. Dr. Arnav, is that the same with you?
Same. Unless this patient would have been 75 plus, hormone positive, I would have not done it. But obviously with this profile, I would have done it. Yeah.
You would have done it. Agreed. Next slide. So coming to adjuvant therapy, starting with Dr. Mansi this time, duration of trastuzumab.
So she's ERPR negative. I mean, I would give 1 year of trastuzumab, which is currently the standard.
Fair. You started with saying ERPR negative. So let me say this patient is ERPR positive. What would you do?
It's still 1 year of trastuzumab, to be very honest. It's, yeah, 1 year.
You're not still convinced with the Persephone?
I think if there is a subgroup analysis of the FAIR study,
right,
which looked at patients with very low risk disease, which did not have any benefit of adding 12 months. That was 2 centimeters or less and node negative.
Okay. Dr. Vishwanath, please complete. Sorry, I'm sorry.
I totally agree with, sorry, Dr. Mansi, please go ahead.
No. So except for those group of patients, I think I would still recommend 12 months.
Okay. Dr. Vishwanath.
I totally agree with Dr. Mansi. De-escalating to 6 months should be restricted to very small tumors, ERPR positive, and we should have a big discussion with the patient as well, because the meta-analysis has also shown not much of benefit with the 6 months versus 12 months. I mean, the 12 months has stood better.
Okay. So if I can ask you, what is this definition of very small?
I'm talking about maybe T1, less than T2. I'm talking about maximum T1C.
Okay, Dr. Preetham, now this actually brings me back to the next point, the backbone chemotherapy for Persephone. Next slide, please. So backbone chemotherapy in Persephone, if you look at the other things, all of them had an anthracycline in it. Whereas if you already discussed before that if you have T1, you would probably just go with the ACT protocol. So do you think 12 versus 6 really matters?
Well, yeah. So if you look at the Persephone trial, the hazard ratio, the upper limit was 1.32. So, that is somewhere we have to take with a pinch of salt. And I think the standard of care with, I think, majority of oncologists is 12 months until unless there is some economical issues of continuing the trastuzumab. Yeah.
Interesting. Meta-analysis, what Dr. Vishwanath was talking about, the original meta-analysis did not include Persephone. It showed that longer was favored both in terms of overall survival as well as DFS. Next slide. The importance is the toxicity, significantly lesser cardiac toxicity. I mean, that's something we should think about. Next slide. Looking at all the studies now, the upper confidence limit for Persephone was 1.24, and that led to that whole discussion of what exactly constitutes an inferior border. The inferiority margins here was taken as 1.25, and it just fell within that. So that's how the trial succeeded. Next slide. So Dr. Vishwanath, this is what you were discussing. This is what Dr. Mansi was telling about, that in Persephone, you had a subgroup wherein ER negative, only taxane, neoadjuvant chemotherapy, concomitant chemo with trastuzumab, which you don't do nowadays as much. These were the subgroups where actually 12 months was superior. So do you still feel that Persephone not so much applicable for us?
Yeah, I would still stick to 12
Perfect.
months.
So Dr. Amishwara has put a comment saying that actually Persephone is the backbone of de-escalation, and it was statistically wrongly defined at the time of trial design. So personally, I would kind of agree with you, sir, with that there is something to do with the 6 months. We have other trials which use 9 weeks instead of 6 months and still tended to show some benefit. However, in the absence of data, it's difficult to really give a conclusive answer. Next slide. So this is where also we discuss. I have Dr. Vishwanath come into this. You know, the last line which I have written, more suitable in India. When Persephone was discussed last year in ASCO, people were not very interested. And one reason they said is, look, we don't practice this anymore. We just give NACT and we use pertuzumab and trastuzumab. So this whole concept of adjuvant 6 versus 12 really does not bother us. What do you have to say to that?
I agree to that. I think in the Indian setting, I think one of the medical oncologists also pointed out about economics. So this does come into play
Right.
for a select subgroup of patients.
I personally agree with you, and at least from my practice, if I'm not able to give 12 months, I'm pretty happy giving 6 months. I'm not denying patients 6 months, saying that you have to have 12 months and make them take no trastuzumab at all. That's my personal philosophy. I think in practice, most of us do tend to add it, but again, as a take-home message, 6 months of trastuzumab for T1, T2, probably okay. T3, node positive, well, probably you will have to have a discussion with the patient. But important to note that if you're giving 6 months, please use both anthracycline and taxane. Giving only taxanes, well, doesn't really have any data for it. So this is the third de-escalation that we discussed. Next slide. So for Dr. Nidhi, from a radiation point of view, this is just a question I'm interested in. In all BCS patients, irrespective of HR status, HER2 status, do you have to give radiation? You have a 75-year-old patient like Dr. Arnav was talking about, who has undergone a PCS. Would you still?
That is the only situation where it may be avoided without any adverse effect on the overall survival and local recurrence rate.
So what's your age cutoff? Where would you say this is fine for me, I will not give radiation? Do you have any data to that?
There is no absolute cutoff. There are various trials.
Right.
Some are talking about 60 plus and others are talking about 70 plus. So generally we stick to 70 plus in our clinical practice because the follow-up is not very reliable in our settings. So it is always better to...
So for me, this has always been a confusion because, you know, for any patient with T2 and 1 also, if they're strong ERPR positive single node, we kind of discourage chemo. We say, look, chemo benefit is 1%, but radiation oncologists have no problem in giving radiation with even 1 node positive. That's just my own biased view, I'm sure. But that's interesting that the data from radiation is mostly for 1 and 2 nodes versus 3 nodes, and it showed that both places it benefited. 1 node ERPR positive, there is no such trial as far as my knowledge. Dr. Nidhi, am I right, or is there any data on that?
No, that is right. And that is what we are following in our clinical practice as well.
Right. Perfect. Perfect. Next slide. So, anthracyclines, necessary or not? Can we omit anthracycline in high-risk EBC? Dr. Vishwanath.
Yeah, I think this ASCO 2020 data has thrown more light on this.
Okay.
That the train to
So you follow, you agree with train to data?
Yes, definitely.
Right.
In fact, the previous one, the BCARG, unfortunately was not powered to assess this. But with the train to data coming in, definitely, I think if we are using dual HER2 therapy, I think that's the way to go.
Perfect. Dr. Mansi, your take on this?
Yeah, so that is a big caveat that you have to use Perjeta if you want to accept the train.
Okay, you are from Ahmedabad, all of you are rich people, you will be using it. Let's assume, I mean, academically speaking.
Yeah, that's the disclaimer.
Do you agree with it?
Yeah.
A disclaimer for everyone.
That's the disclaimer. Yes. And the only other thing with the BCRG 006 trial was that there were not a lot of patients with more than 5 centimeter tumors. So if with inflammatory breast cancer or patients with M3 disease, T4 disease, we don't have a lot of representation with that population. So in those patients, I still use anthracyclines, but other than that,
earlier than that, you're happier with TCH, if I can understand.
Definitely.
Right. Dr. Preetham, what's your take on this?
Yeah, you know, we in those patients who are with comorbidities where we are using TCH as a regimen, okay, and you know, the train to trial if you are using Perjeta. Otherwise, I would say you know, anthracycline should be the part in HER2 positive breast cancer.
Should be a part, not omit. You should be a part. Except if they're contraindicated or complications.
Yes.
Very good. So again, I think the data is a little this way, that way. Next slide. So this is the BCIG 006 that we are all talking about, wherein group 1 got AC and docetaxel together, TAC protocol, which I personally don't really use it. Group 2 had ACT plus trastuzumab, basically AC followed by trastuzumab, and group 3 was TCH. Next slide. They found that the TCH as the inclusion criteria included invasive high-risk node negative or node positive patients. Primary endpoint of DFS. Next slide. They found that the DFS was almost equal for the TCH and the ACTH. And they found that it provides similar and significant advantage in low and high risk, but toxicity is better. And I think that's something we all are interested in. So again, like all of the panelists are saying, if you have a node positive, a higher risk, probably you would be a little tempted to not omit anthracyclines. That's if I can make that conclusion for all my panelists. Correct. Next slide, please. So this is, supposing the patient has a lymph node palpable and pre-op HR negative, Dr. Anaga, such a patient, T2, N1 clinically small node palpable, pre-op HR negative and HER2 positive, NACT versus surgery.
I would still want to give her a trial of NACT if the tumor size is more than 5 millimeters.
No, more than 2 centimeter tumor. It's
NACT always.
NACT always. Very good.
Yeah, in this case.
HER2 positive case. Very good. Yeah. Next slide. Okay, now this is the TRAIN-2 that we have been all talking about. So next slide. This was a 3-year follow-up of NACT. Now, for me, the problem really in this study is look at the chemo that was given. They used paclitaxel, carboplatin, trastuzumab plus pertuzumab, followed by 6 cycles. So you gave 9 cycles of paclitaxel, trastuzumab, and pertuzumab, and carboplatin. And the other side, you gave 3 FEC along with trastuzumab. So combining epirubicin with trastuzumab and pertuzumab. I don't think we ever practiced that, giving anthracycline and trastuzumab together. And then you did a surgery. Next slide. The primary endpoint was only a PATH-CR. Okay, the event-free survival was secondary endpoint. That was similar in both the arms. Next slide. The subgroup analysis did not show any benefit for anthracycline in this group. Next slide. And by nodal status, when they looked at N2, N3, there was a benefit of adding anthracycline, but otherwise in N1 and N0, there was no benefit. Next slide. So overall survival at this point seems to be equal in both the arms. So Dr. Vishwanath, you were supporting TRAIN-2. You said anthracycline time omitted, but 9 cycles of pacli-carbo. Is it feasible technically? I mean, we don't use that much chemotherapy.
I do agree. This is a difficult regimen to follow.
Right. So are you tempted to do this? Are you tempted to just give 6 cycles and then take a call?
Yeah, I would give 6 cycles.
Okay, fair enough. It's a tough question. It's a trick question. There's a googly. There's no answer to this. Right. Next slide. So their conclusion was that there was no benefit for an anthracycline containing regimen. Personally, I would still be tempted, especially if you have higher risk tumors, and I will discuss later. Next slide. Right. So, Dr. Diva, are you still there? You had not joined us in the beginning.
I'm there. Am I audible?
Oh, thank you. So, yeah. So, how do you interpret a response to NACT? Dr. Vani did discuss this in the previous session, but quickly, how do you assess the response radiologically to NACT?
Yeah. Basically, the first modality to evaluate the response of NACT is we do the ultrasound, and just to first of all to see the what is the morphology of the tumor, like is there any circumscribe or the lesion is present or not, just a fibrosis is present. And then along with
ultrasound is good enough for that.
Yes.
Okay.
And ultrasound is good enough, and for necessary, if there is just a fibrotic bands, like the clip placement will suffice, like further. No other modality will require.
Okay, perfect. So in practice, Dr. Anaga, do you get a scan done pre-surgery? I mean, this was discussed by Dr. Vani in some detail, but I'm just asking as a practice, what do you do?
A scan as in an MRI scan?
MRI or a PET or an ultrasound, what do you do?
No. So I always go with a mammography with a good ultrasound and a MRI in certain cases where I see the density which is high or irregular. Now, as far as evaluating, I would like to take that question also as to how would I interpret the response radiologically or depend on what? would depend upon what was my pre-therapeutic imaging, concomitance between the different modalities. If my palpatory findings, my ultrasound findings, my mammography findings, and my MRI findings were in sync with each other, then just an ultrasound would suffice. A mammo would only be required if the patient had a pre-therapeutic microcalcification. In a patient who has fatty breast and a single lesion on a pre-therapeutic scan, just an ultrasound should be good enough.
Very good. So I will not get into more of this because this all has been discussed by Dr. Vani in quite some detail. Next slide, please. So this was another paper which somehow did not get as much air, but it's very interesting. A Ferg-Gain study, again from this ASCO, where they did a de-escalation protocol using FDG PET-CT and pathological CR responsive therapy. Next slide. Now in this slide, when they did a protocol, they actually was a very complicated protocol. Next slide, please. Yeah. So what they did was they gave pertuzumab and trastuzumab only, no chemotherapy in one arm, did a PET-CT after 2 cycles, then again tried to look at a surgery and then assess the PAT-CR. And those patients who achieved in the PET-CT positive group a PAT-CR continued on only pertuzumab and trastuzumab. Next slide, please. Ravindra, can you get to the next slide? Yeah. So this was the model. It's a little complicated. Please go back to ASCO 2020 and look at it. It's a very interesting study. Next slide. What they found is that, next slide, in the patients who achieved PET complete response, around 40% in the pertuzumab trastuzumab arm, another 40% went on to get only pertuzumab and trastuzumab. Next slide. Next slide. And in those patients who did it, around 40% of these, they had a 3-year survival similar to those patients getting chemotherapy. So for the first time, you're actually seeing a complete chemotherapy-free protocol, which seems to give a response based on the response in PAT and PET-CT. So this was interesting to me. It's only 3-year follow-up. We should look for longer follow-up, but this is something that can help us decide in future. Next slide. Yeah, Ravindra, next. Yeah. So, Dr. Vishwanath, this was another trial which really promised a lot. We had Ferg-Gain, which was depending on response based on PAT and PAT-CR and PET. When you had a Christie, which included TDM1 and pertuzumab, this study failed. So, do you think the dual HER2 is kind of dead in the NAC, in the thing, or chemotherapy is a part of NACT for all patients?
Well, I think the previous study which you quoted is, it's too early to say because it's only looked at pathological complete response. That's number one. And we have seen excellent pathological complete response with TCHP, and it has stood the test of time. But I do say that there is, I wouldn't think of TDM1 in the neoadjuvant setting.
Perfect. Dr. Mansi, TDM1 in neoadjuvant too early, or we can still think about it? Yeah, Dr. Mansi, you are muted.
Yeah, I think it's too early. I think
too early. Okay, next slide. So we will not do Roche any favors in this meeting. We will not say that we will give TDM1. My 4th de-escalation is the evolving role of omitting anthracyclines based on PET-CT and PAT-CR. But remember, this is evolving. We do not start practice on this from tomorrow. Okay. Dual HER2, however, seems to be in the practice, which includes trastuzumab. So basically, trastuzumab and pertuzumab are really coming into a big way in the neoadjuvant setting. Not TDM1. That's about it. Next slide. So in a LABC, last slide, couple of slides, we have just touched 657. I have just 1 more minute to go. A 53-year-old lady, large mass, 6 centimeter, fixed to the skin, fixed nodes on PET-CT, ERPR negative, HER2 new, HER2 new 3+. Next slide. Any of my medical oncologists would want to go for de-escalation here? Dr. Mansi, if I can start with you.
No, no.
No? TCH with FEC, or do you go with ACTHP?
I would go with ACTHP.
ACTHP. Dr. Preetham?
ACTHP, yeah.
ACTHP. Dr. Vishwanath?
I agree.
Perfect. So that's another important takeover. We all want to de-escalate, but remember, there is not every case you can de-escalate. There are occasions where you actually have to escalate, and Catherine has taught us that we have to escalate if you don't get a PAT-CR. So that's also an important takeaway message. Next slide. So to summarize, trastuzumab was a breakthrough in breast cancer because it heralded the onset of personalized therapy. Now we are even further personalizing HER2 based on the T stage, based on the N stage, based on PAT-CR, based on PET report. So de-escalation when it comes to, right now, we would consider treatment only for those patients above 0.5 centimeter or 1 centimeter, up to 2 centimeter for sure, 3 centimeter probably. You can de-escalate anthracyclines, give only trastuzumab and trapacli. You probably do not need Perjeta in this situation. Shorter duration of trastuzumab to be discussed with patient. Definitely in early low risk, 6 months is good enough if you're giving your anthracycline. If you're not giving anthracycline with a TCH protocol or a TH, please give up to 1 year of trastuzumab. Larger tumors, node positive, adjuvant TCH, omitting anthracycline is a good option, but typically these patients should go for an NACT. Ideal world, go for a dual HER2, followed by omitting chemotherapy completely, not a standard of care, but maybe you can think about that in the future. That would be my conclusion. So if any of the panelists have any other thing to discuss.
There is actually a comment from the audience.
Yes.
So I guess they wanted us to comment on this JGO article. Recent paper in JGO on cost effectiveness of short course trastuzumab finds it cost effective in early HER2 positive breast cancer, and probably in low income and middle income country like ours, this should be considered more strongly.
Okay, so I just take that question. I mean, this whole idea of cost in India is a little difficult to assess because, you know, as someone close to me keeps saying, India is a poor country with a lot of rich people. So for rich people, they would probably want to go for the full 12 cycles. But yes, like I made a comment, if you have to give trastuzumab and patient has issues, please give at least 6 months. Do not omit trastuzumab. That's the take-home lesson. If you cannot afford 12 months, give 6 months, no problem. But do not omit trastuzumab. That should be the take-home here. So thank you, Dr. Mansi, and thanks to the organizers again.
Thank you, Dr. Mansi.
Thank you, Dr. Mansi.
Thank you so much.
Thank you.
Thank you. Thanks a lot.
Thank you,
Thank
Mansi.
you. Bye.
So, Tanavir, if you want
Yes,
to invite the next person.
So, very informative sessions and quite an excellent discussion till now. So with this, we enter the last leg of our today's program, which will comprise of 2 panels. And for this session, we'll have Dr. Shakuntala Shah Madam as a chairperson. She's a very senior and excellent oncosurgeon hailing from Ahmedabad. She's a very good teacher and she has served as an head of the Department of Surgical Oncology at PCRI, and many oncosurgeons all over India have been her students. She has many publications to her name in various prestigious journals, and it will be an honor to have her as a chairperson in this conference. So I hand over to Dr. Shakuntala Shah, Madam, please.
Hello.
Yes, Madam, you are audible.
Yeah, okay, fine. So I just, because I couldn't connect my video, so I'll just be talking, okay, till I can connect it.
Fine, ma'am,
so,
fine.
Yes, fine. So as you know, the perspective of oligometastatic breast cancer, the scenario has changed a lot, you know, and we are getting good cure in some patients, good prognostic patients. So today I'll be chairing this session, and we can start off with the panel. And whoever are the panelists and the moderator, I invite them to start the topic. Hello?
Dr. Shalaka, are you there?
Yes, I'm here. Can you hear me well?
Yes.
Okay, so I'll start sharing my slides right away. Thank you, Madam Shakuntala. You can see my slides?
Yes,
we can see the
slide. All right, okay. So I have been given this topic of oligometastatic breast cancer, where I need to be more of a clinical oncologist than a surgeon, and like how we should be treating these tumors with a multidisciplinary treatment plan. I have a multidisciplinary panel here, 2 radiation oncologists, 2 medical oncologists, and 2 surgeons. So we'll be quickly going through why do we really bother so much about oligometastatic breast cancer when we have accepted no surgery for metastatic breast cancer. What makes oligometastasis a different set and a different entity? And then we'll go through a few clinical situations. I will be directing questions to a couple of people at the most. And if everybody agrees with them, then we need not have more discussion and quickly go on to the next slide. So I would like 1 radiation oncologist, 1 surgeon, and 1 medical oncologist to define for me what is oligometastatic breast cancer, what is the exact burden, and why do we want to really treat it differently. So Dr. Kinjal, Dr. K.S. Gopinath, Dr. Akasha, you could go in this order.
Okay, so when we talk about, as you rightly mentioned, that now, oligometastatic disease, earlier we were not operating the patients who had a metastatic disease. But now in a few conditions like a breast disease where there is an oligometastatic condition or a rectal disease with an oligometastatic condition, we think about treating them with a curative intent. So patients with less amount of metastasis, we give them the systemic treatment, and then we plan to do a local treatment to achieve the maximum loco-regional control as well as to increase the survival. So if you define the oligometastatic disease, it is a variable thing. Few people prefer, if there is a 3 metastatic sites, you can still consider it as a oligometastatic. There are few studies which says 5. So it is around 3 to 5 metastatic sites along with the primary that is considered to be oligometastatic condition.
Right, Dr. Gopinath or Dr. Akash, your opinion or any guidelines that we should follow?
No, actually, all the Dr. Akash here, and all the guidelines have different definitions. But the intention of this oligometastasis is now initially we were keeping these patients as metastatic disease. Now we want to cure these patients. So our intention is changed from palliation to cure. So which patients we can cure? So it is 3 to 5 metastases, and which metastases are accessible metastases. So it should be 2 or 3 maximum organs. So that is important. Intention is if we are the metastases are accessible, then it is known as oligometastasis. It should be 3 to 5.
Right, Dr. Gopinath or any other surgeon? Sir, are you there? Or any other surgical oncologist would like to take this?
I think it is.
Any one of you?
Gopinath, sir. Gopinath,
Okay,
sir, go ahead.
I think the size of oligometastatic disease is also important. Number and size, both are important.
Right. So as everybody has correctly said, the definitions have really been variable. 3 sites, 5 sites, 3 centimeter, 5 centimeter, accessible, possible to give either surgical or local treatment, radiation. These were the varied definitions. So the only guideline that's really available for us today is the ESMO guideline, ASO-ESMO guideline. And that talks about it should be low volume metastatic disease, limited number and size of metastasis, up to 5, and not necessarily in the same organ. So you may have a contralateral axilla with a single bone met, and you could still treat that as oligometastatic. It should be potentially amenable for local treatment at the metastatic site as well, and it should be aimed at achieving a complete remission. So as far as the burden goes, 10% of breast cancer is metastatic at presentation. A lot of them will still relapse in the next 10 years. 10 to 20% of MBCs are likely to be oligometastatic now, because we are doing much more imaging, much more PET CTs. Like Vamshi said, the medical oncologists like to do PET CTs. So we discover few lung nodules, we discover some mediastinal nodes, and we discover far more oligometastatic disease, which we wouldn't have otherwise discovered if we were just doing an X-ray, ultrasound, and bone scan. So we know it's a metastatic breast cancer per se is a spectrum of clinical behavior depending upon site and extent of the metastasis. And there are gene expression profiling, which has shown different prognostic subtypes, which may be true even in the metastatic setting as well as in the operable and locally advanced setting. And we have always known that the outcome of oligometastatic breast cancer is intermediate between locally advanced and polymetastatic disease. So Hellman introduced the term in 1995, and we came to use the term more often of oligometastatic breast cancer. There are some translational studies which have shown that if you actually try to do gene expression profiling of these tumors, you could cluster them into particular subsites like polymetastatic and oligometastatic actually club together, and they may be actually different subsets. So you don't really need to put all your eggs in the same basket. So the next question is, how do we really go about diagnosing these, and what is the initial workup in this oligometastatic breast cancer? Dr. Nikunj and Dr. Pinaki.
Diagnostic workup is same as other breast cancer only. Ideally, we should go for the PET scan, means initially starting from the true-cut biopsy, and ERPR, HER2 status, and Ki-67, and PET CT scan or the bone scan is must. And after that, blood workup and the fitness ECOG status is very important in this patient, because if patient general condition is good, then and then we can go for the curative intention. Because
Yes.
in this patient, we ideally should go for the first chemotherapy and followed by the local treatment in majority of the cases. So patient general condition should be evaluated first.
Yes, and do the medical oncologists think differently, or it's
No,
the
I
same
think
kind of
Dr. Nikunj summed it up. So I think the investigations that we are doing routinely for locally advanced as well, and the performance of the patient is the key factor there.
Yes, absolutely. And nowhere in this session, I guess we would be debating that systemic therapy is the first treatment of choice. So I'm assuming that as the baseline, that systemic therapy would be the first choice of your treatment. And you need to definitely discuss with the patients, assess their fitness very well, and see if they are really able to tolerate all the intensive, aggressive, curative treatment that you're going to offer them even in stage 4. So just quickly to get to understand whether we have a consensus among us on polymetastatic breast cancer. So Dr. Nikunj and Dr. Pinaki, would you offer surgery if the patient has not oligometastatic, but frankly, polymetastatic breast cancer?
In current scenario, we are not offering the surgery to polymetastatic breast cancer, except in a palliative setting where the tumor is fungating or painful, or patient has a local problems. Otherwise, in current scenario, we are not offering the patient in polymetastatic breast cancer the surgery.
So we are also doing the same. I mean, in a palliative setting where you have fungation or bleeding, then only we are offering. Otherwise, we are not giving it.
Absolutely. So we have agreement here. I think we have a lot of data from retrospective studies which actually showed that there was probably some benefit by surgery in metastatic breast cancer. These studies were hugely biased, selection bias, because the women who actually got surgery were having much favorable outcome per se. And again, a meta-analysis also showed that it favored surgery. Of course, they all had biases of retrospective studies. And then we have 2 or rather 3 randomized controlled trials today, which have kind of put a nail in the coffin of surgery for metastatic breast cancer. And the reason for this could be multiple, that there are animal level studies or basic scientists have actually done research and shown that if you remove a site of primary, then the metastatic sites could actually be growing. And this was done back in 1970s and 1980s. And now in 2019, we have a proof that surgery doesn't help in metastatic breast cancer. There are multiple theories behind it. And now we have, I think, a consensus that we should not be operating unless, as everybody said correctly, for infection or bleeding or fungation or for improving quality of life. So now, do we have similar strong consensus on oligometastatic breast cancer? Can some metastatic breast cancer be cured? The discussion must have started long back in 2002. And in 2010, actually, the first consensus got published for oligometastatic breast cancer. So what is our consensus of our panel? I could put the question to Dr. Akash, Dr. Devnarayan, and Dr. Sanjeev Patni.
Yes, so for current consensus is for oligometastatic breast cancer is we should try to cure this patient. So that is the first thing. And so we should start with systemic, as you said before. We should start with the systemic treatment, and in between also, and at the end of the whatever we have planned neoadjuvant chemotherapy. It's so first of all, it should be neoadjuvant. It should not be labeled as the palliative chemotherapy. And at the end of the treatment, patient should be reassessed. And if there is very good response to especially metastatic sites, then we should try to primary and to target metastatic sites also.
Right. Dr. Devnarayan Datta, the radiation oncology perspective on this?
See, now in all oligometastatic disease with low volume disease are treated with systemic therapy to start with. But there is a counterpoint on that when you start giving chemotherapy in these patients, especially if someone is having a lung lesion or liver lesion, they disappear. And once the chemotherapy is over, 6 cycles of chemotherapy, then again come back. It is unless until we define where the disease is and start the chemotherapy, then it is very difficult to target it with reduced radiation or radiotherapy or reduced surgery in when there is a good response with chemotherapy. So that point has to be taken into account if we start the systemic therapy in this kind of patient.
Yes, absolutely. And I'll come to it when we discuss the case scenarios, how we would like to kind of mark the sites of the metastatic disease, if at all we need to do that. But the current consensus for us is that we are treating them with an aggressive intent and a curative intent. We are not treating them like polymetastatic breast cancer. We are not treating them like locally advanced breast cancer. We are treating them like oligometastatic breast cancer, where we give systemic chemotherapy first, choose our patients who are responding well, then go for local regional treatment, which could be mastectomy mostly, but yes, it could be breast conservation in select patients. And the metastatic site as well needs to be treated. If we were to follow the 70s and 80s experiments, where if you remove the primary, the metastatic site could grow, then taking care of the metastatic site could also mean something in these patients actually. And probably that's where the thought to cure the metastatic or treat the metastatic site also comes in place. So look at, if you do a bit of a SWOT analysis of the retrospective studies, you actually see that the studies which said that surgery is favorable in metastatic breast cancer, 75% of those patients were actually solitary or oligometastatic patients. Even in the meta-analysis by Harris of 2013 that I showed earlier, majority of patients were actually who had surgery had oligometastatic breast cancer. So there is this famous paper from Japan which looked at 30 years of data of oligometastatic breast cancer, 2 to 3 organ sites involved, and at 103 months follow-up, they had a substantial good outcome, 59.2% 10-year overall survival. And if local therapies were given, then the survival to the metastatic sites, then the overall survival was even better. So I think it's widely accepted, and we have a consensus here again that a select subset of patients with metastatic breast cancer should be approached with a curative and not a palliative intent. Although we do not have a high level of evidence here, and it's evidence level B, it is still acceptable to us now. So the different clinical situations we come across where you come across oligometastatic diseases. One is the patient at presentation could be oligometastatic. There could be oligo recurrence in the follow-up where you would like to treat them aggressively. And it's a little debatable and questionable, maybe, oligometastasis at the end of systemic treatment in polymetastatic MBC, and I'm not really getting into that controversy. So we'll start with our case discussion, which could be a little more helpful to Dr. Michelle Shah and Dr. Pinaki Mato. This case is a 58-year-old lady, postmenopausal, diabetic, hypertensive, but good performance status. Left locally advanced breast cancer. On imaging workup, she was found to have a lung nodule which was 1.5 centimeter. That was quite suspicious of metastasis. We didn't really FNSE it, as most of us may agree. It's really difficult to FNSE the small lung nodules. We almost believed that this was a metastatic breast cancer. And sorry, how would you take this, Dr. Michelle and Dr. Pinaki Mato? So how do we start treating this patient? Of course, she's triple negative and she's oligometastatic breast cancer.
So considering that she's oligometastatic breast cancer and she has a lung nodule, we would like to start with systemic therapy. And we generally, with a triple negative patient who is 58-year-old without, and who is having comorbidities, we'll have to assess whether she's fit for anthracycline chemotherapy. If she's fit, then we'll give a combination of anthracycline and taxanes. And then we will reassess after the chemo. Yeah.
Right. So she actually came from an outside medical oncologist to us who believed in aggressive treatment as well. And she had already received 4 cycles of cyclophosphamide and 4 cycles of paclitaxel. There was a PET done post chemo and that showed near complete response. But the lung nodule was seen. It was persistent. It had slightly reduced, maybe from 1.5 to 1.2. But it was persistent. So Dr. Michelle, as a surgeon, what would you offer her? What kind of surgery? Here. Maybe you need to unmute yourself, or Dr. Sanjeev Patni could take this.
I think if this lung nodule has not responded to chemotherapy and we had no tissue diagnosis to begin with for the metastatic site, it is doubtful that whether really it is metastatic or not. So in that situation, now I will treat it as a locally advanced breast cancer and do whatever surgery is required, because I have a doubt whether this lung nodule is really metastatic. Because we have given a therapeutic trial to that, the lung nodule must have responded majority of the times.
Okay. Any other opinion here? How one may want to approach the lung nodule?
Yes,
if one has to be.
I would like to biopsy once if it is not. It's a non-metastatic, because so many times we see that few metastatic sites respond and few metastatic and they don't respond.
Right, and that's often our way of selecting patients, especially when mediastinal nodes are involved and which are only doubtful and not very conclusive. But this patient's daughter was a doctor. That's a different story. We had extensive discussion with her, and we had done an FNSE which was inconclusive. So she was fit for surgery, and she tolerated the chemotherapy also quite well. So she was keen on conservation. It was a 6-centimeter tumor which had become a couple of centimeters at the end of chemotherapy. We did left breast conservation surgery, and her workup for fit surgery and even VATS metastasectomy was quite okay. So we ended up doing a pulmonary VATS metastasectomy for her. She went on to get local regional RT for the breast, and luckily the right lung nodule turned out to be a hematoma for her, and the relatives were.
That is what I was saying.
Yeah. But the next case I would discuss, the patient was not so lucky. This patient was lucky, but we had deemed her as non-metastatic almost, and some people were not really agreeing to offer her surgery. That's why she had come to us. Then this is a case too where 68-year-old lady came with a right-sided operable breast cancer. She was HER2 positive, ERPR negative, grade 3, and she had 2 right lower lobe lung nodules, as you can see here. I couldn't get the CT images of the previous patient because they were done outside. So Dr. Kinjal and Dr. Sanjay Patni, how would you go ahead in this case? HER2 positive elderly lady with a OBC, but having 2 lung mets, suspicious lung lesions.
I think I would let Dr. Sanjeev Patni sir, take a call first. How would he feel about the surgical part first? So let him, give an opinion about the surgery upfront. Then I'll
surgery upfront. First of all, we will have to try and prove the lung nodule whether it is metastatic or not. And as the CT scan shows, it is a peripheral region. So I think an FNAC or a biopsy is feasible. It's not a deep-seated lesion. So first of all, we should get a diagnosis for the lung, and then we decide about the local treatment.
So if FNAC is positive for lung met.
FNAC is positive, then naturally it will go for a neoadjuvant chemotherapy. Considering it to be oligometastatic, we go for a chemotherapy.
Sorry, please go ahead.
Yeah, the same question that, if these lesions would disappear post-chemotherapy, which is likely, then what would you do? And that's more likely with triple negative and HER2 positive breast cancer patients. Anyway, in this patient, what actually ended up happening was she wasn't willing to, she had some fitness issues. She was 68 years old. She was node negative. So we ended up operating her first, and we did an upfront MRM and VATS pulmonary metastatectomy. Again, we have a strong thoracic team with VATS metastatectomy today has much lesser side effects as compared to an open metastatectomy for lung mets. These are peripheral lesions. They could be easily done with VATS. The HPR was a PT2 1 node positive with 2 lung mets, and then the patient went on to receive further adjuvant HER2 directed treatment, and her first follow-up scan was normal for mets. Again, the one-off situations I need to discuss with the patient. You may do an FNAC. If the FNAC comes positive, that's an additional help. Many times it comes inconclusive, or the radiologist is not able to really do it. So a lot of data regarding lung mets in other cancers like sarcoma, some data for lung mets in breast cancer, and it is shown that the 5-year survivals, if there are solid oligo lung mets, that is less than 4 in number, then the 5-year survival is not so poor. And the better prognostic factors are if you have pieces in the pulmonary mets after treatment, and if there is a DFI of more than 36 months, and if you can get a complete metastasectomy with a negative margin, and if they are on the same side, only 1 lung involved, then they have a better outcome. So again, a meta-analysis.
Dr. Shalak, if I may come in, how do you decide when do you do a surgery upfront followed by adjuvant chemo?
No. So the decision is, like I put my disclaimer right at the beginning, was it's always systemic chemotherapy first in oligometastatic breast cancer. It's just one-off situations, elderly patient, and you may not be sure about her compliance with chemotherapy. Then you may consider doing surgery first, and especially if it's really early breast cancer to begin with. But generally, they would be locally advanced and systemic therapy first. Yes, that's the take.
So the message that we want to give to the audience is that we would start with chemotherapy first.
Always.
But this was a one-off case where you would
one-off case.
Yes. Followed by adjuvant.
And then again, multiple studies. This is a Chinese meta-analysis, 2,000 patients, and again, 5-year survival after pulmonary metastatectomy was 46% if they had all the good prognostic factors. So to case number 3 is to Dr. Gopinath or Dr. Nikunj, in case Dr. Gopinath is not there, and Dr. Devnarayan Datta. This is a 46-year-old lady, premenopausal, right locally advanced breast cancer. She was having a palpable left contralateral, that is axillary lymph node, and the staging PET showed the right breast and axilla, and left axillary lymph node, that was contralateral lymph node, which was positive on PET as well as on FNSE. Left breast imaging was normal, so there was no contralateral breast cancer. So we are not dealing with a bilateral breast cancer case, which is something we would like to make sure in this case. And we had a biopsy from the left axilla to make sure it was the same histology and it was positive. So as we said, Dr. Gopinath and Dr. Devnarayan, how would you approach this case?
This patient received neoadjuvant chemotherapy followed by surgery?
Yes. So she got 4 cycles of epirubicin, cyclophosphamide, all the chemo first, triple negative breast cancer, 12 cycles weekly, PACLI. A repeat PET showed a good response. There was good response in the breast axilla and as well as the contralateral axilla. So the surgeons in the panel, how would you approach this now?
Of course, we need to go for the surgery. On the right side, MRM, modified radical mastectomy, and left side axillary lymph node dissection.
Yes, so she had a right mastectomy and a left axillary clearance, and she went on to get radiation to the right side alone. Alone. So this is I guess the radiation oncologist will agree with this. This treated like a solitary metastatic to the contralateral breast. The breast was normal on imaging, mammography as well as ultrasound, and she got radiation to the right side alone. So this is another case of contralateral axillary involvement. Dr. Nikunj again and Dr. Pinaki, a 58-year-old lady treated earlier in 2002 after 15 years of DFI. She got node in the same side supraclavicular region, and the PET scan a region in the breast, as you can see, an IBTR. So the PET scan showed right breast lesion, right supraclavicular, and contralateral axillary lymph node. The biopsy of the lymph node was a biopsy from the breast was TNBC. So how would you approach this?
Here the DFI is a very good 15 years of DFI. That is very good period. So we need to re-challenge the patient with a neoadjuvant chemotherapy. And depending on the response, we further decide.
Yes, so patient got 6 cycles of acli-carbo and repeat PET showed partial response. So what would be the next step now?
If response is looking on the PET, the SU value and the lesion size is decreased more than 50%, still I would like to go for the curative intention, as earlier DFI is very good. So we give the curative intention. Patient should undergo bilateral axillary dissection and right supraclavicular fossa dissection.
Yes, so she had an IBTR, so she had a completion mastectomy, a supraclavicular fossa clearance on the same side, and a contralateral axillary clearance. And this is not really a debate here, but we could discuss the role of re-radiation, the radiation oncologist in our panel. And maybe the patient can get re-radiation because of the long TFI. But that's not the contention of today's panel, so I wouldn't discuss that in detail. So contralateral axillary lymph nodes incidence is low, and this is treated as an oligometastatic site, and whenever surgically removed or treatable, we should go ahead and do the contralateral nodal clearance or supraclavicular clearance. And we have a reasonably good overall survival of 82.6% at around 50 months, and outcome is better than overtly metastatic disease. So this case 5 is for Dr. Kinjal and Dr. Devnarayan. Yes.
I think the previous DFS of 15 years has no bearing on the DFS this time, because again, it's a metastatic disease, triple negative. She has a IBTR and a supraclavicular and a contralateral axillary node, and it's likely to fail. She's not likely to have a DFS, a long DFS this time.
Maybe. I wouldn't totally agree with that. She definitely didn't behave like TNBC. She got a late recurrence, which is unlikely in TNBC. But the point of the case was that these are my real cases in the hospital. So how would you treat the patient? Would you offer her a cure at all because she has had a long DFI, because she's fit, because she's 48 and she's young, and because these are all treatable and manageable lesions, or areas which can be approached with surgery.
Yes, so, but the prognosis is much poorer this time.
Yeah,
definitely agree with the prognosis, but we should give the trial.
Treat her with a curative intent.
The intent can be curative. The intent can be curative.
Intent can be curative.
And the patient has to be explained about the prognosis now.
Yeah. Like all oligometastatic breast cancer patients, I guess we would have to tell them that they are stage 4, and this is curative, generally not a curative intent in stage 4, but because they have limited disease, we could try to give them a curative intent treatment without a high level evidence, but with robust retrospective prospective evidence that we could do this for these patients. So next case is purely radiation oncologist case. So I am putting both my radiation oncologist here. 54-year-old lady, postmenopausal, treatment completed earlier, DA5 of 4.7 years, strong ERPR positive, came with back pain and on MRI and PET as well, had isolated D10 metastasis as you can see here, and no other symptoms of spinal cord compression or mechanical pressure symptoms at all. So how would you treat her?
So looking at the MR picture, it is very clear that there is no cord compression, and this patient can very well be taken as a curative intent treatment as far as the radiosurgery is concerned. And Dr. Datta, my friend, is a pioneer in the cyberknife radiosurgery. He has I think the maximum experience of doing a cyberknife. He would be itching to do a cyberknife for this patient. So this is a very good case for a SBRT. Just for the people to know, the medical and the surgical oncologist. The SBRT or a radiosurgery is possible in a tumor which is not compressing on the spinal cord. If it is compressing on the cord, it is very difficult to spare the cord. But looking here, the involvement of the body and going towards the pedicle, not even involving the pedicle, this is a good case for treating this patient with a SBRT and a curative intent treatment. I think Devnaran can take it in details.
Yeah, so that's why I put up this case.
Yes, yes.
So sir, how would your approach be?
If it is this spine is stable and there's an oligometastatic disease which is not compressing the spinal cord, then radiosurgery is a very decent option, and that is going to relieve the pain and have a local control as well. So we will, as I prefer, and now the data is that to treat with single fraction, 24 gray single fraction or more than 16 gray single fraction for this disease, and that can have a long-term control if it's only bone metastasis in breast cancer.
Yes, absolutely. You seem to be agreeing with our radiation oncologist, because this slide is given to me by Dr. Reema Pathak, and she also gave 24 gray single fraction SBRT to this patient, and she went on to get next line of hormone therapy alone, along with bisphosphonates, because she didn't really need chemotherapy. So radiation.
Can I just make a comment here? Can I just make a comment here?
Sites is the norm. Single fraction 8 gray. Yes. Yeah. Yes.
So if we get a case like this, like in your case, it was a recurrent in the bone. But if a patient comes with a solitary bone lesion like this, and the patient is given neoadjuvant chemotherapy, and then patient is operated, in such a scenario, I and Dr. Vijay have treated a good number of patients where we have treated the patient with a surgery and the adjuvant radiotherapy to the primary site, as well as treating the bone metastasis, a solitary bone metastasis with a SBRT or a radiosurgery.
Yes. Yeah. Yes, that would be the way to go if this patient had upfront metastasis at presentation. Yes. So this has traditionally been followed as a conventional single fraction or multiple fractions. I don't really need to tell you what are the reasons to give multiple fractions. You probably know them better than me. SBRT is the current way to go, and we have enough reason to believe that MBC with bone mets do well. Oligo recurrence with bone mets do well, and oligometastasis with only bone mets also do well. A lot of retrospective data to treat these bony mets, if they are less than 5 in number, of course, and localized and not widespread in 5 different bones of the body, then we could treat them with aggressive intent. And they have a reasonable survival. Earlier, single fraction versus multiple fraction, there was a meta-analysis. They found to be equivalent except when you had compression symptoms. Now, this study published in April 19, you again know it better than me, where colorectal and lung mets were treated with SBRT, with just one little disclaimer that my radiation oncologist colleagues keep telling me, that there is a little higher chance of complication if one is not careful. So maybe for all the younger radiation oncologists in the audience, that one needs to be careful and learn SBRT well, I guess, if they have to really practice it. So case 6, and this is my last case, or maybe one case after that, is for Dr. Akash Shah, Dr. Michelle Shah. You have this 43-year-old lady, premenopausal, and she has T2N1 breast cancer, IDC 3, 8, 8, and HER2 negative. PET showed 2 lesions in the lung, one in segment 4B and one in segment 6. And Dr. Gopinath, I just saw he joined. So sir, if you could also comment on this case, what you would do. These liver metastases were targeted with an ultrasound guided FNSE, and they were positive.
If these are the only 2 metastases in the liver, today we have an option. Just get one good 3D CE/CT of the liver with 3D print, doing the 3D pictures, if it's localized to these two segments, what they have done. Today, there is an option for number one. If you have good facilities, one can think of SPRT for these things. Otherwise, even the radio frequency ablation, one can think of RFA versus even microwave therapy for these kind of things.
Yes, sir, absolutely. So we like how the concern was raised even earlier that what if these liver mets or these lung mets disappear when you start chemotherapy, which is often the case with liver and lung mets. Then you could clip these liver mets, and that's our practice before starting chemotherapy. You give 4 cycles of chemotherapy, repeat a CT scan response assessment, and if there is decrease in the tumor, so if there is a response basically in the primary as well as the metastatic site, then you go ahead, we operated on the patient, did a mastectomy, and targeted both the liver lesions with radio frequency ablation. This is slide given to me by Dr. Nitin Chetty from my hospital, who's the interventional radiologist, and we do these procedures maybe 1 or 2 in a month. And this was the first PET post-response. PET would show a complete metabolic response. Some signs may remain of the scars of the liver of the previous metastasis, but generally they show good metabolic response. So again, this patient is probably not so lucky, but as you can see on the CT scan, it's a little bigger size of met. This case is again to Dr. Gopinath, Dr. Patni.
Ma'am, can I just, I'm sorry to interrupt you, but we have a few questions from the audience. So if you just want to wrap it up. Yes, yeah. That would be nice.
Yeah, sure. So again, this patient after first MRM and another recurrence, she recurred again in the liver. And this was the kind of picture, well-to-do family and was keen on treatment, single site of metastasis, and we ended up doing a right hepatectomy followed by some more chemotherapy for her for the liver lesion. So we know that liver lesions, if they have limited presentation, then they have better outcomes than polymetastatic liver lesions. And whether this is an exercise in selection bias or whether we are really offering them a benefit is a matter of discussion with the patient. But currently with these non-invasive treatments, it may be feasible to do so, to offer them little less invasive treatment than a hepatectomy and do either RFA or TACE or interstitial brachytherapy also. And they are showing good median overall survival of around 22 months. Lastly, brain mets, Dr. Kinjal and Dr. Devnarayan, I will just quickly come on to the slide that again Dr. Reema gave me. How do you approach brain mets which are solitary or a few in number?
Up to 5 metastases, we can do radiosurgery easily, but it all depends, if a patient on treatment failing or, patient presenting with a metastatic disease with a small primary, we have to be very cautious. The picture which you are showing, the upper 3 photos are of a radiosurgery and the lower 3 are of a hippocampal sparing radiotherapy. So, patients are worried about the neurocognitive dysfunction. So we can do a hippocampal sparing at the same time, give a boost. As you can see in the last 2 images on the right bottom side, there are high dose regions where give a radiosurgery boost to that area and do the whole brain radiotherapy with hippocampal sparing.
Yeah,
so up to 5 minutes. Yeah.
That would be the modern treatment of brain mets with radiation. And so last slide for me, and the take home message again is that we need to confirm that they are oligometastatic. Sometimes you need to do a couple of more imaging like MRI of the bone, or for the lung you may need to do an FNSE, also for the liver, to really confirm that they are oligometastatic. Systemic therapy is almost always offered first, and you select your patients, maybe a little bit biased here, but you select the responders. And if a patient is progressing and becoming polymetastatic, then you wouldn't want to treat them. You select your patients who have good performance status, good ECOG, and you discuss with the patient and they should be willing for the curative treatment. And then you treat the primary site with a mastectomy or conservation, usually a mastectomy again, and you treat the metastatic site either with surgery or local radiation. Thank you. So we are ready to take questions.
Yeah, I would just like to say, Dr. Joshi, that if this is like we are discussing the single system oligometastasis, but supposingly we have 2 or more systems, then the question becomes more complicated. Then probably still we should think for a curative intent if it is involving 2 organ systems. But I am not sure about 3 or more.
Yeah, true. I agree. So this discussion, and this is like personalized treatment, you really need to, this is case-to-case discussion, and it's usually an MDT discussion for us. We are not deciding singly.
Okay, so if I can go with the audience questions. The first question is, in case of a contralateral axillary nodal met, I'm assuming that is the only site of metastasis, should you irradiate the contralateral axilla after axillary dissection?
No, I think only axillary dissection, no radiotherapy.
Agreement.
Only surgery.
Because of the concerns for, of course,
concerns for the complications. Yeah, the lymphedema and all.
Okay. And then the other question is, can we do breast conservation surgery for a patient with oligometastatic disease that we are treating with curative intent?
Definitely, we can go ahead with, but surgical margin should be available. Resection margin should be R0.
The BCS will depend on the primary stage of the tumor, what are the size of the tumor and what else. Because BCS practically, if we are doing it with a curative intent, I think it can be done if it is a small tumor with oligometastasis. T1, yes. T2 tumors with oligometastasis still can be considered for a BCS, but larger than those tumors, again, then all the things have to be done for that. And depends on how the response of chemotherapy is, how the location of the tumor is, all those things have to be considered.
Okay. And then the other question...
Because the intent is curative here in oligometastatic, which we planned.
Okay.
Dr. Shalaka.
And the other question... Sorry.
Yes. Just a minute. Dr. Shalaka, my question to you is, I think both the TMH study did not show an overall survival benefit when surgery was done with the primary intact. And the ECOG Seema Khan study you referred to also did not show an overall survival benefit when surgery was done with patients even with oligometastatic disease. So what is it?
So we are talking about polymetastatic breast cancer there. So the TMH study particularly excluded oligometastatic patients. So the intent for oligometastatic patients, even when the one study was going on, was curative. So oligometastatic patients were excluded from that. And regarding the ECOG-ACRIN study, I'm not sure if the full text is available, but from what slides I have available for Seema Khan's ASCO 2020 presentation, our 40% patients had bone mets. The number is not mentioned, so whether they were single, 2 or 3 or 5. And 40% patients, so 40 to 45% had visceral mets, unless the Turkey study, which was 75% almost bony mets. So that probably had a bias, and that's why they showed benefit in surgery. Maybe they had a more of a oligometastatic group there, which was published in 2018. But I'm waiting for Seema Khan study's full text because I really want to see how many were oligometastatic. Okay. There's another study, Japanese society study is also going on right now, 0107 or something, which is looking at metastatic, and that also includes oligometastatic. So that will be interesting to see. But as of now, we don't have randomized evidence, and the retrospective data is more in favor of surgery and aggressive treatment in oligometastatic breast cancer.
Agreed.
Shalaka.
Yes, sir.
See, now you do your own TMH data is emerging. Do primary surgery for even in a metastatic disease. Because earlier your concept was don't do primary surgery for a metastatic disease. I've seen some presentation from TMH itself, and recently somebody had sent it to our IJSO for article. The primary surgery should be done, and then you plan the systemic treatment. What is your take home from these two studies, past study and the present study?
So presently, we are not doing a study in oligometastatic. The study that we published in metastatic breast cancer, the M1 study, was excluding oligometastatic patients, and there were majority of them were polymetastatic breast cancer patients. And they, I think the concept always was that in multiple metastatic breast cancer surgery is to be done only in the presence of infection and bleeding, and there was no other indication to do so. It's just that the retrospective data was so had put so much pressure that people were still operating in metastatic breast cancer based on the retrospective data, which was heavily biased. And that's why the randomized evidence that came up first with our study and the Turkey study, which were actually contradictory. But then when the ECOG-ACRIN study got discussed in ASCO 2020 this time, we were all very happy or maybe relieved to see that they had similar results to ours, that surgery did not help in multiple metastatic breast cancer. I'm not sure which data, and we always, if you see the study of our M1 study design, it was systemic therapy first and responders were selected, and so was that was not the way it was in the Turkey study, where they randomized first to getting LRT versus to get not to get LRT with systemic therapy, and that's where probably the difference in the two studies, that one was a positive and one was a negative study. But when you select your patients out after giving systemic therapy first, then there was no benefit in the responders of doing local regional treatment, and I think that is what TMH policy has been. Except for oligometastatic breast cancer that we have been treating with aggressive intent. Yes, sir. Yes, Dr. Devnarayan.
Why do you feel now with this SBRT coming into the picture, now the CIPLA study has come, which has shown that radiosurgery can be a good option in oligometastatic disease in breast cancer as well. So where do you see the surgeries in oligometastatic disease?
So you mean to say radiosurgery of the metastatic site, right?
Yeah,
Or
radiosurgery for the
the local, yeah. So the bone mets, the lung mets, we have started doing SBRT for those. Not maybe so much for lung mets yet, but definitely for bone mets, SBRT is being done. And of course, we have phase 3 data from the Saber Comet study again, but we have only phase 2 published, but 99 patients, but still a promising study. And regarding other sites of metastasis like liver and lung, whether you would want to do SBRT or whether you would want RFA or microwave ablation, I think that could be the institution's choice. As long as there is ablation and you have a post-treatment response which shows no metabolic uptake, I think that should be good. Is what I think.
Am I allowed a quick question?
Maybe the site of the lesion as well. It is
Tanabhai, can we like wrap it up? Like last question from your end, and then we move on to the next panel.
Yeah, a small question to Dr. Pinaki and Dr. Akash. So I would like to know whether for oligometastatic luminal A subtype, whom we have treated by curative intent, NSCT is over, we have done a good surgery, and then the patient comes to you for adjuvant endocrine treatment. So will you combine it with pulbase or ribociclib, or you'll just give letrozole alone?
Again, being a metastatic, it is always better to give dual hormone therapy.
Okay, thank you.
The quick question from the audience: does anyone mark the metastatic site prior to giving?
Only the liver. The liver needs to be marked.
It is with liver. Liver has to be marked.
Okay, great. Thank you, everyone.
Thank you so much. Thank you, everybody.
I
think we agreed on most things.
Majority of the things, yes.
Yeah, thank you, Dr. Mansi and organizers.
Thank you very much.
Shakuntala ma'am, do you have it? Thank you. Shakuntala madam, do you have any?
Thank you, Shalaka, everyone. Thank you.
Questions? Shakuntala madam is there, or? Ma'am, you are muted.
Am I audible?
Now, yes, you are now.
Yeah, so the take-home message has been given by her, Dr. Shalaka. That was a well-conducted session, covered almost everything on oligomets. And yes, the marking for the liver, otherwise how do you do the prostatectomies? But what about the lung lesions?
That's often a problem. So we have seen that if there are 1 or 2 lung lesions, we are giving systemic chemo, and if they completely disappear, then we don't really do anything to them right now and keep them on a CT scan follow-up. But if something is persistent and yes.
So fine. So yes. So that was well taken, and I think we can wind up this session, and let's go to the next one.
Yes, thank you, madam. I think you may remember you took my MCH exam in 2012. She passed.
Did I?
Me.
Okay. Just before I retired from CCRI. Okay. Thank you. Yes, Tanay, Mansi.
We can now welcome.
Yes, ma'am. We can go ahead with this last of our panel that is on lipoplastic breast cancer.
You can start the slide share.
Hello.
Yes.
Hello.
Okay. Can I start?
Yes, please.
Yeah. Good evening, ladies and gentlemen. This is the session on realities of breast reconstruction, Indian practice. I'm Dr. Ashok. I will be the moderator, and I have today an excellent panel of plastic surgeons and breast surgeons who have experience in both oncoplasty and complete breast reconstruction. Let us for next 45 minutes pick their brain and find out what is in for breast reconstruction in India. This is our panel. Dr. Hari is from Coimbatore. Dr. Pradeep Goyal is from Jaipur. Dr. Raghuveer Solanki and Dhanisha are from Ahmedabad. Dr. Manish Kaushal is the odd man out. He is the breast surgeon from Indore. and Amit Patil from Mumbai. Except for Kaushal, rest all are plastic surgeons who are into reconstructive surgery. So we'll ask questions and find out what needs to be done about reconstruction of breast in Indian patients. So we all know that this is nothing new. Breast cancer has emerged as the leading cancer among Indian women. It's about 27.7% if you take only female cancers, and 14.
You need to share your screen.
Not coming?
No.
Not coming. Oh, sorry. Please share your screen. Okay. I thought I shared. 1 minute. You share.
Yes.
Okay. Here are we. Yeah. So the leading female cancer now is breast cancer, and the incidence is about 12 to 28 per lakh of population. That means about a lakh of new patients we see every year. And we also know that now it is affecting younger patients as compared to the West. That means more and more early cancers and younger patients we are treating. But contrary to what we see as cancer, the number of reconstructions are abysmal in India. This is the graph telling that as compared to 25 years ago, presently we see lots of younger breast cancers. So naturally they should be opting for breast reconstruction, and we don't see so many breast reconstruction. Hari, can you pitch in and say what is the reason why we don't see so many reconstruction as compared to West in terms of numbers?
Number one, in the West, it is directly offered as part of the insurance package. That is the first reason. Second is, it is a combined treatment. So basically the oncologist and the reconstructive surgeon both are together when they see all patients in most of the centers, the leading centers. And then depending on, just like we decide in a tumor board, in fact, in the previous session, as we saw, it's a combined opinion of the radiation oncologist, surgical oncologist, and the whole team. So here we can decide if it needs what kind of reconstruction, and usually it is done as a combined treatment modality. And second is, of course, most of the Indian patients, as we all know, earlier was in the elderly age group. So they are quite happy with disease clearance. So the reconstruction part was not given a priority by the patient themselves. Of course, and the last reason being less number of reconstructive surgeons available. So I think a combination of factors.
Dr. Manish, yeah, you want to add as a breast surgeon, is there anything else you need to add to these points what Hari made?
The most important part in India is socio-economical conditions and the limitations of the plastic surgeons in small remote areas. Like in our city, the most of the plastic surgeons are not in favor for the breast reconstruction. They engage with the hair transplant and other things. So the basic problem is that it's a training part, and apart from the socio-economical condition.
So there was a study done by Dr. Raja Shanmugakrishnan from Ganga, and he also found out that awareness among the patients, which we always quote as a lack of reconstruction, was quite high, and lots of, about more than 50% of the patient whom 10,000 patients he interviewed, they knew something about reconstruction, and about 70% of them wanted reconstruction provided there were certain criteria, especially economical criteria being met. So again, coming to BCS was mastectomy. In urban specialty centers, we see 60 to 70% of patients with breast cancers undergoing BCS with some kind of oncoplasty. But if you take overall, all over India, it's only about 10%. Manish, this question is for you. What is the reason for this wide disparity against urban and rural area in terms of BCS and oncoplasty?
But the most important factor is the training and the concept, because in most of the part of India and rural India, every surgeon understand only one surgery, that is the modified radical mastectomy. They don't have the knowledge about the oncoplasty or breast conservation surgery or breast reconstruction. And the second thing is the limitations of the availability of the plastic surgeons in the rural area. And the another factor is the lack of the facilities like the radiation, radiotherapy, because in all cases of the breast conservation required the radiation. So these are the limiting factors.
Yeah. So BCS and oncoplasty also requires facilities like frozen section and radiation. So these lack of these in remote areas would also hinder BCS as compared to mastectomy, right?
Definitely.
Yeah. And see, when we do BCS with oncoplasty, there are 3 zones in the breast which are very, very critical, what we call as problem zones. The superomedial quadrant called no man's zone, the central quadrant around the nipple and areola, and the inferior quadrant tumors. These pose a serious challenge to the aesthetic outcome after doing a BCS. We'll take one by one and see what options we have and what can be done in these areas. Basically, this is because of lack of tissue which we can borrow either from inside the breast or from outside. The reach and so on and so forth would cause the aesthetic results to be very, very inferior. So we need to be careful. Here is a lady with a moderate side breast with 65-year-old, stage 2A cancer, T1N1 lesion, grade 2 IDC in the superomedial quadrant, which is about a centimeter and a half in size. Manish, when you see this kind of patients, if you want to offer oncoplasty in such a lady, what are the things you would look for in terms of deciding what procedure you want to do?
Sir, it's we should consider, because this is a small tumor and situated in the upper inner quadrant. So we can offer it's a level 1 oncoplasty, where we can go for a simple wide excision, no skin excision, dual plane undermined dissection. And although our tissue dissection is less than 40 gram, 20 to 40 gram, if we want a more tissue dissection, then we go for any matrix rotation mammoplasty. But I think that for this case, the level 1 oncoplasty is sufficient.
Okay. So between the size of the tumor, the breast size of the breast, and the location of the tumor, what do you consider is the most important factor in deciding the procedure?
For the considering of basically there are 3 important factors: excision volume, tumor location, and glandular density. So this patient is a 65 years old female. So probably the fatty content, maybe the fatty content is more. But for this patient, the most important factor is the volume of the excised tumor, excision volume.
Okay. So because the tumor is slightly away from the nipple and the nipple areolar complex is small, what we did was we approached this tumor directly with a radial incision. As you said, we excised the tumor in 3-dimensional factor dimensions, and we mobilized both the pillars, the superomedial and inferolateral pillars, and we closed the wound like that. And this is the pre-op, and that's the post-op picture. Gives excellent results if the volume of the tumor is up to 20% of the overall breast volume, correct?
Yeah.
Yeah. And here is another lady, 42-year-old, upper medial quadrant, and T1 lesion. The size of the tumor is much bigger as compared to the breast of size of the breast. What kind of reconstruction you would advise? Does it need a volume displacement or a volume replacement procedure?
So this patient, again, I think it's we can consider for the volume displacement. We can go either by the inframammary fold rotation mammoplasty or matrix rotation mammoplasty.
Okay. Because the volume was slightly bigger, what we did was did a volume replacement, but a slightly different way. What we did was we rotated the glandular tissue into the primary defect and used MI cap flap to replace the secondary defect. This is a new flap we have devised for upper medial quadrants, especially smaller ones which are reaching to the middle quadrant. This is the tumor which was approached with, as you said, from inframammary fold, and 2 perforators were identified, and that's the flap that was elevated, and this is the post-op result. So more than 20% of volume, we should always consider volume replacement. But superomedial quadrant, if you borrow tissue from the back, either LD or one of the perforator flaps like TDAP or LTAP, the distance it traverses through the breast causes a lot of distortion of the breast and gives asymmetry to the breast. So local flaps are much more ideal for in such scenarios. Again, somebody had biopsied this and turned out to be malignancy. When you see such patients, you have to excise widely, right? More than normal because of the induration it causes after the surgery. So when you have long, big skin loss and tissue loss in a small breast like this, where would you borrow tissue from, doctor? Anybody else? Tanush is absent. I think he has gone for an emergency. So Manish, you are the only one who has done some local oncoplasty. So what would be your flap choice?
Dr. Raghu has good experience of doing thoracoepigastric flaps and LD flaps.
Yes. So Raghu, would you comment on the choice of flap here?
You are muted.
Yeah, am I audible? Yeah.
Yeah.
So it depends upon the excision, but I think in this region, it would require the help of latissimus dorsi myoperius flap because the skin would be excised. Again, the depth of the tissue is up to the pectoralis fascia, so it would be the whole full thickness defect, and you need a good amount of soft tissue and skin coverage, and it would be better easily filled with LD flap.
Okay. Any other flaps if LD you don't want to use it?
You can LD is the most easy flap. The recent advance is in either one of the perforators from the lateral thoracic wall, either the thoracodorsal perforator or the intercostal perforator, depending upon where you find the good signal on or Doppler.
All right. So previously we used to do this, take an LD and put it there, and it would heal fantastically. It got a lot of blood supply. You can pick enough volume to fill it. But what it does is, if you see here, there is a little bit of bulge which increases because it is coming from the lateral aspect. So this was the previous main mode of reconstruction if you had volume loss and we had to do volume replacement. Another case, a small breast with a large quadrantectomy kind of a lesion.
Ashok.
Sorry?
Dr. Ashok, would you have done a small microvascular reconstruction for the previous patient?
This one?
Yes.
Yeah, you could. That's what I'm coming to. I'll show the next case. This is
okay.
So, superomedial quadrant, quadrantectomy kind of defect, small breast, and patient is young and doesn't want big surgery from a large scar on the back. What we could do is we can take free flaps either from the lower abdomen or from the upper thigh called the tug flap or the SIA flap. And this is the tumor and this is the flap that has been harvested. And we can plug it onto one of the intercostal perforators. And this would be the result at the end of it. This is the pre-op and this is the post-op even after radiation, except for the scar, it is beautifully healed. Now, there are enough, we have known that BCS oncoplasty gives very good results in terms of aesthetics, in terms of safety, both loco-regional and long-term survivability. But from time to time, we see this kind of papers, whether oncoplasty is really a fashion or necessity, claiming that there is a lot of complications and delay in adjuvant therapy. So in such a scenario, is free flap and overkill to do such small defects? Hari, you would like to comment? Hari?
Yeah, once you have excised the defect or created the defect, you can nicely see the intercostal perforator or even the internal memory perforator. So the the perforator of the intercostal itself is quite sizable. So for the size of tuck flap or what basically it's a gracilis pedicle, so the size match will be perfect. So it's a good flap to do, and you are only taking adipofacial component. You don't need any skin.
Correct. So in terms of time required as compared to an LD flap, would it make a huge difference?
Hello, Ashok.
Yeah.
Yeah, there is some echo in Ashok, your mic. I think some cell phone is on or
no, nothing is on.
So time, I don't think will be a different more because you can do it as 2-team approach. And normally in our setup, we do as a 2-team approach. In fact, sometimes 3-team approach. So once they are doing the dissection and creating the defect and identifying the perforator, the intercostal perforator, harvest of gracilis will take only around 35 to 40 minutes. So we can keep it ready and then just go in. In fact, there is no change of position. Sometimes in LD, you need to change position. Most of the time, we don't try to change the position. But time-wise, I don't think it will take much time.
That is what we have found, because it's a 2-team approach and no change of position. The time is not a factor at all. Okay, we'll go to the next quadrant. That's the central quadrant. This is a lady with a 53-year-old with left-sided tumor excised some just below the left nipple area complex and turned out to be adenoCA. Manish, what's the plan in such a scenario when you have a recurrent or a residual tumor?
Sir, we can go for either inverted T skin incision, free nipple graft, or we can go for the Grisoti flap.
Okay.
We have 2 options.
Because the incision was made through the nipple areola and the tumor was very close to nipple areola as the previous surgeon has mentioned, this patient underwent Grisoti. That's the tumor, and that was the post-op changes we could see. Somebody else's mic is on, I think. So we did a Grisoti flap. This is a perforator flap based on 4th and 5th intercostal perforators. And we keep this skin as skin island, rest all is de-epithelialized. That's the defect that was created. That's the plan of a flap. And it was completely islanded. The original Grisoti says keep the lateral attachment to the skin intact and move the whole thing as a pedicle. But this is the modified Grisoti where you completely island it. The movement is very good and aesthetic results are much better. And you close it like that, and this is what you could achieve with doing it Grisoti. So this is a very good flap, but 2-3 things you need to consider. The breast size should be sizable, at least a B cup or above, and undermining should not be too much, especially in the inferior aspect. Then it becomes difficult to do this flap. And some amount of asymmetry you need to accept at the end of it because there is some volume loss.
Doctor, if I may come in, would you have considered a bilateral reduction mammoplasty sort of scar in this patient?
If you see the size of the breast here,
yes, significant ptosis on the opposite side. So maybe a reduction on both sides.
See, the choice will then depend on what the patient would agree for an opposite side symmetrization or not. So one of the things that we have to consider when we offer any kind of oncoplasty, always utilize the ptosis or the size of the breast for doing a therapeutic mammoplasty or a therapeutic mammomastopexy kind of procedures. It gives excellent result provided patient agrees for the opposite side surgery. So there is an option to do if they agree for opposite side surgery. Now, sometimes the lesion is slightly bigger, and when we excise the nipple and adjacent area, quite a bit of volume loss can happen in patients. In such scenario, Grisoti might not be helpful. That is the defect. Again, as Raghu, your flap, would you explain what would happen if you take a lot of muscle and put it here, whether over a period of time it would reduce in volume or muscle would survive and it still give a good result in the long term? Raghu?
And most of the muscle flap, they get innervated at the time of harvesting, and over the time they just got atrophied. So they don't give any kind of bulk long term, and majority of the patients, they get radiotherapy. So after radiotherapy, again the volume loss happens. So most of the volume is only with the fat that we take with whatever flap we add in such kind of patients, either a free flap or local regional flaps. So try to add the bulk with the flap which has very good amount of the subcutaneous fat. I think such kind of flaps should be chosen.
So this was, as Raghu said, we did an LD, mini LD flap, and that was the flap. Take extra fat instead of lot of muscle, and then you fill it up and tunnel and put it inside. And this would be the long-term results. There would be some amount of tug that happens to the lateral aspect because of the weight of the LD, but overall the results are fairly good in. So the advantage.
One more comment. So I want to ask all the surgeons: do you cut the nerve to LD?
So I wouldn't cut at all. Yeah, almost all cases when I don't cut the nerve. The syn kinesis which happens is very, very rare, and I haven't seen one in this thing, but it will help to prevent volume loss significantly. That's my experience. I could ask Dr. Amit, what is your experience? Do you cut LD nerve?
Mostly nowadays LD, if it is used along with an implant, where we see animation more of, I think those are the only situations where we need to cut the nerve, where we are using implant and to try to avoid animation, any kind of animation. But I think routinely we need not cut the nerve. It generally atrophies over, disuse atrophies the eventuality.
So what is your experience with harvesting the muscle? Does it leave any donor site morbidity? Are you worried about it?
So basically, whenever the breast surgeons they excise the main specimen, they always enter the axilla through the same incision. They never take a separate incision. So while approaching axilla, there is always a loss of tail of breast. There is a fat loss in the breast tail also. So LD with muscle also gives some kind of tail to the breast tissue. So that's it. If there is no loss of breast tail, I think TDAP flap would be a better option rather than LD muscle with muscle.
My question to you was donor site morbidity when you harvest muscle.
Of course, there would always be there. So I think TDAP is the choice.
Okay. Yeah. So preferably now the shoulder function disabilities, long-term disabilities are known to happen if you cut the muscle. Whenever possible, do a TDAP flap as compared to a muscle flap. Is that fair enough comment? Hello. Next, this is a 58-year-old lady who had a left breast cancer, lower inner quadrant. That's the mammogram, and the lesion is here. It is biopsied, and it turned out to be IDC in the lower quadrant, T2 lesion. What's the option for this kind of BCS? Dr. Manish, you have experience in this?
We can consider for the J-plasty or inverted V scar plasty. Only concern about the lower lesions.
Okay, absent in such scenario. What we did here was something called AI cap, anterior intercostal perforator flap, which are 2 or 3 perforators here, which arise from the 6th intercostal space, and they can be Dopplered, and we can harvest skin and fat from this area, and it can be recruited to fill this. This is that was the tumor, and the tumor was excised from inframammary fold, and what we did is we harvested the whole of the flap, made it into a ball, and we put it inside, and the surgeon excised the biopsy site also. and it was closed. And this is the immediate pre and post-op, and this is late post-op picture, and almost identical breast shape after doing this surgery. When we do this AA cap, you need to think, if you don't do this, we'll produce something called a bird beak appearance, which is very, very nasty deformity. And the problem with AA cap is the volume of tissue which you can borrow is not too much. And the reach is maximum in a smaller breast, it will reach up to the nipple area. And you need a Doppler to Doppler before you do this kind of reconstruction. Upper outer quadrants, very, very yielding area. You get lots of options for these kind of lesions. You can directly excise and close it like a level 1 oncoplasty, or you can borrow tissue from the back for these kind of lesions. That's the tumor. And this lady, when they started, that was the lesion that was marked, and that's what they said they will remove. But when they did the frozen section, the DCA has kept on becoming positive on the margins. So they had to go and this was the plan actually. First plan was to do a level 1 oncoplasty, and then we thought we'll mark Eli cap flap for filling this. But once they removed, it was a huge defect, almost removing 2/3 or little more than 2/3 of the breast. Nothing was left. So we had to change the plan, and LD and becomes a major source of flap here. This is what we did. And immediately after radiation, this is how the skin was looking, and that's the donor site. It heals well, hidden inside the bra line, and not major problem. And this is the post-op picture. This is the original main workhorse in the local flaps, what we used to do. But these days we have 3 flaps from the same area. You can recruit the same amount of skin and fat from the back. This is the thoracodorsal perforator flap based on thoracodorsal vessels. This is a LTAP flap based on lateral thoracic artery, which is just running along the lateral border of the pectoralis major, and Eli cap, which is the 4th, 5th, and 6th intercostal perforator. You can harvest depending upon where the lesion is, upper lesion, middle lesion, lower lesion. You can flip and close these defects. The donor site will be just a line. So there is a large paper with a large series from Vani Parmar from TMH, which says it is safe enough to do partial breast reconstruction for extended indication for conservative breast surgery for breast cancers. They said it is safe enough to do. And this is one example where we could do a partial reconstruction. My question to everybody is, if we are doing so much excision in the breast and still subjecting the lady for radiation, can't we do complete mastectomy and do an autologous reconstruction and spare radiation? What would your comment, Dr. Manish?
I think the oncoplasty is better option, because the if we go for a complete MRM with the breast reconstruction, because it takes a longer, the surgical duration is much more, and only the sake of the radiation. So I think it's better to go for the oncoplasty.
Hari, what would you say? Is it better to do partial reconstruction and give radiation, or to do a complete mastectomy? And
yeah, partial is, I would say, definitely better, because now radiation has become much better. So the image actually which I saw, what you presented, I asked our oncosurgeon whether we get so much darkness, dark skin changes after radiation. He says nowadays it is
very, very rare. She reacted very badly. Yeah.
Yeah. So I think wherever partial is possible, definitely
should go ahead and do it. It's safe enough.
Yeah, we always reserve our micro option for a later date, and it is always a better option, unless, of course, like you said in the last case, where there is so much volume excision, and then so there is a change of plan, then you can have both options in mind. But all the other first few cases which you showed, I think partial oncoplastic is definitely better.
Look, Vani here. Can I just
please
comment in the panel?
Please.
So you asked a very important question of can we not just do away with radiation and just do a mastectomy whole breast reconstruction? If you ask the radiation oncologists, the indications for radiation have gone up so much that even with one node positive, there is a post-mastectomy radiation that is offered. So the indications for radiation are much more now. And in fact, doing a minimal surgery for the patient is obviously something that the patient appreciates as long as you don't give too many scars. But yes, a whole breast reconstruction has its own charm because eventually it gives a tummy tuck and the patient is happy both ways, as long as there is no failure on the procedure. This is an absolutely brilliant procedure. So hats off to all of you for doing a whole breast reconstruction as well. That's all. Thanks.
Yeah. So coming to therapeutic mammoplasty, Dr. Amit, would you be able to shed some light on what are the requirements when we have to do a therapeutic mammoplasty? What are the requirements for?
I think cup size is more important. Cup size, a larger breast. I mean, only those can be offered. The other problem is the symmetry is the other important thing, which is again hit back in Indian scenario.
Okay.
So that is the two things I think more important.
Is site and size of the tumor determine whether you want to offer therapeutic mammoplasty?
There is a larger size. Of course, the patient would undergo some neoadjuvant chemotherapy, and they would rather try for this thing rather than directly going for BCS.
Okay.
If the size is lower, along with clip application. The other problem is of clip application before NSCT, and there is going to be a migration after therapeutic mammoplasty. So that things again needs to be considered for the radiation, subsequent radiation.
Okay. If the site of the tumor is not in the regular area where we do excision of the tissue for
basically no man's area, upper inner. I think pedicle, I mean the central quadrant again is this thing, supromedial pedicle and the inferior pedicle. I think they suffice. Or just in case if you feel that the main lesion is lying in some one of the pedicles, I think bipedicle is the other choice.
So you can play around with the pedicle to see where the tumor is and orient your pedicle accordingly, right?
Yeah.
Okay. Is there a risk reduction by doing opposite breast reduction surgery? Is there a reduction of risk of cancer itself?
Not really.
Manish?
There are some studies which they mentioned, but for these studies not in favor in younger age group. In after the 40 years, most of the studies claim there is some benefit of the risk reduction.
Yeah, that's a study from Sweden. Exactly what you said. There is a 39 to 50% reduction, but it is not significantly lowered in women who are less than 40 years of age. So some reduction happens after 50 years, but not basically below 50 years. Raghu, this is for you. There is a lesion here on the superior medial quadrant, large 56-year-old large breast, T2 N0 M0 4 centimeter lesion. What kind of therapeutic mammoplasty you would offer? What is your plan for pedicle?
In such case, the inferior pedicle is spared, and some part of the medial or some part of the supromedial pedicle is can be done. So medial pedicle, pure medial pedicle, or inferior pedicle is one of the base technique along with the opposite side reduction.
Fantastic. So what we did actually was we did a superior medial pedicle like how we do. We are very used to this for breast reduction on the normal side. And because the tumor was sitting in the area where the pedicle would come on the affected side, we did an inferior pedicle plan. So you can play around with the pedicles depending upon where the tumor is. And sometimes if the tumor is sitting in areas where it is not primary excision area, we can take secondary pedicles and fill that cavity as well, which is called extended therapeutic mammoplasty or extreme therapeutic mammoplasty. Here, this is the tumor that was excised. That's the defect area. This is the inferior pedicle deepithelialized. And this is immediate post-op, early post-op, I would say. And this is after radiation. Excellent results, and gives very good symmetry to the patients. So coming to total breast reconstruction, we have three kinds of reconstruction that can be offered. Autologous, that is patient's own tissue, implant-based reconstruction, and hybrid variety where you combine autologous with implant-based reconstruction. Dr. Amit, could you tell the advantages of, I'll put up all the advantages of autologous breast reconstruction. Could you tell about effects of radiation on autologous reconstruction?
I mean, of course, the autolog is always preferred because it tolerates radiation well, but there is definite volume reduction, and there is always the skin changes. So the whatever volume we are putting, it's a higher amount, so that we contemplate the volume reduction over a period of time.
Hari, any comments on your experience of radiation on autologous reconstruction?
Yes, definitely there is some shrinkage of volume. So you can err on the side of adding more volume. Skin changes were not much. We don't, because as I said, but there are skin changes. So, but definitely it is, we find it autologous is a definite advantage for the field and for the patient.
What is the difference between an infection in an autologous breast reconstruction and an infection in implant-based reconstruction?
I think that we have not seen so far. Amit,
no. So my majority of experience with autologous reconstruction and very few with the implant. So literature says the infection is more with the implant-based reconstruction, and the autologous reconstruction they got infected. So I think literature-wise and from my experience, autologous reconstruction is anytime based. Implant-based reconstruction, theoretically, what we go through all journals and literature from the Western world, they say that the infection rates are much more compared to autologous.
And once there is an infection in the implant, it is almost a failure, complete failure, right?
Almost complete failure, and it has to be removed. And even after effects are very bad.
Exactly. So if there is an infection into the autologous, there is a possibility of salvage with antibiotics and good debridement, and with implant based, most of the time it is a complete failure. So that being said, there are disadvantages of doing autologous. More surgical trauma, more time consuming. Flap failures are a reality we need to be worried about, especially in a single team or a single man reconstruction team. And donor site morbidity we need to consider, and definitely longer recovery. And if there is a complication, it is delaying neoadjuvant therapy. So these are the main disadvantages we need to look at. So this was slightly older paper, but they compared the immediate and delayed reconstruction by tram flap actually, and effect of radiation. And they advised actually not to do immediate reconstruction because the long-term complications of asymmetry and hard breasts with fat necrosis much higher, and acute complications were pretty much same whether you did immediate reconstruction and radiation or radiation followed by a delayed reconstruction. So the plethora of flaps are available, both pedicled and free flaps for our reconstruction option. What are the consideration when you choose one flap over other? Dr. Hari, would you put some thoughts into it?
So our thought is basically we go for DF flap as our sort of gold standard for complete reconstruction. But if there is less volume, very thin patient, or if there is some problem in the donor site, like a midline scar or some perforators are not there because we do CT angio in all cases, then our second go-to flap is a tug flap. I think we very less do lateral or I gap and S gap. And also we have not done any pap flap also. So I think basically it is between DEP and TUG. And of course, if both are not an option, then a pedicle LD.
So body habitus, marriage and childbirth, and patient preference come in your decision making?
No, not exactly, because even unmarried, we have done DF flap, and married also with cesarean, we have done DF. So DFs is okay because donor side is quite good. And TUG, of course, you need to have very low volume and hidden scar. So preferably TUG is only for thin patients. Unmarried patient, TUG is actually as the donor side, you have to be careful.
TUG is transverse upper gracilis flap, which is harvested from the upper medial side of the thigh, based on gracilis.
Sometimes if you are not careful and you go more medially, there is a minimal risk of lymphedema in the lower extremity. So that's why you have to be careful with the upper gracilis.
So, Dr. Manish, this question is for you. These are the 3 types of mastectomies you do: MRM, skin sparing, and nipple sparing. What are the indications for these? When will you do one over the other?
MRM is usual to MRM. It's basic for the where the tumor is involved in the large tumor where the oncoplasty is not possible. So in that cases we go for the MRM. Skin sparing, and then these are the cases where we can offer in cases of the family history of the breast cancer, where we can go for the risk of the breast cancer in future. So in that cases we can go for the nipple area sparing mastectomy.
Okay. So if you are doing a nipple area sparing mastectomy, is there a special care you need to do take when you are preserving the nipple? Do you need nipple scrape histopathology to be sure?
Yeah, definitely. We send a specimen for the frozen section. But actually, we have very few cases. I have not accommodated with this type.
So, what are the implications of doing these kind of mastectomies in terms of aesthetic outcomes? Dr. Amit, would you be able to comment?
You are muted.
Can you repeat the question?
Yeah, so we have 3 kinds of mastectomy. What are the implications of these kind of mastectomies at the end result of the reconstruction? Does it matter?
I mean, it does matter in MRMs because most of the flaps, like in DAP, if there is a nipple sparing mastectomy, we can use the skin part. I mean, the fat is always there, but the skin part can add on to the volume. But when there is, when DAP is not an option, and if MRM is done, I mean, there is skin loss, the other tuck flaps and IGAP flaps, they definitely do not add enough volume to supply both parenchyma and the skin defect, both of them.
Okay.
So that is the major problem.
So we need a lot of skin when we do MRM, and it reflects on ultimate aesthetics, right? Yes. As compared to a skin sparing mastectomy or a nipple sparing mastectomy, where the most of the flap acts like a filler and gives much better aesthetics in terms of ptosis and the volume and the projection and everything. So from standpoint of view, the MRM reconstruction as compared to a nipple sparing, as compared to nipple, it goes in a higher grade, right? You would agree with that? So what are...
Dr. Ashok, I think we'll give you another 5 minutes to conclude this session.
Sure. Give me. So these are the points you need to consider when we do mastectomy, reconstruction. When we do mastectomies, the skin, the base or footprint of the and volume of and the projection of the breast and donor site and recipient vessels, and patient factors like desire, expectation, stage and prognosis of the disease, comorbidities, habit, and monitoring aspects. Habits basically is smoking, what we need to consider. So DF is considered the gold standard, and this is the flap against which all the other flaps are measured. Dr. Raghu, could you briefly explain what is DF and TRAM and MS TRAM?
Okay, so for breast reconstruction, originally the pedicle tram has come. So where the blood supply is connected through the part of the rectus muscle. After that, the refinement of the microsurgery, the free tram muscle, free tram flap came, in which the whole of the rectus abdominis muscle is taken along with the supplying blood vessel, that is a deep infioepigastric vessel, along with the overlying skin, and the blood supply to the overlying skin is through the perforators, which passes through the muscle, the entire muscle, and it supplies the overlying skin and fat. With refinement and with after knowing the blood supply in detail, we can spare some part of the muscle, medial or lateral or central, depending upon where the perforator traverses through the muscle, and we can spare the muscle along with the nerve supplies. There are three varieties of the MS tram, and if some part of the muscle is spared, it is called muscle sparing tram, where some form of muscle is spared, so it could function normally, and that is called MS tram. And the DF, that is the latest perforator flap, where the whole perforator is traced through the rectus muscle to its origin vessel, that is deep infioepigastric vessel, sparing the function of the muscle, because the nerve supply of the muscle is spared, it is not damaged, and only the skin, underlying fat, and the fascia where the perforator enters, and the main vessel, that is deep infioepigastric vessel, that is called DF flap.
First class. So,
Dr. Dhanushya has completed his emergency and he has joined your panel.
Fantastic. I will ask him questions. So, this is the plan for a tram, and this would be the plan for harvesting the dia flap. It's very easy. Take whole muscle here as compared to dissecting through the muscle and sparing the nerves there, which prevent secondary abdominal problems. The abdominal donor defect is in tram is huge. We need to use a mesh here, but in tram, I mean in DIAP, we can directly close it. And Hari, you wanted to talk on CT angio. What is the role and why it is so important to do it in diaphragms?
Yeah, so CT angio is very important because they have found, and we have also found, that it reduces the intraoperative time by nearly 45 minutes. And we know the perforators which are good, and we directly go to the perforator, so the harvest time is much reduced. In fact, there was a random study which was done where they did the CT angio, but the registrar was not allowed to know the findings, and he raised it on the other side, on each side. So one knew the finding and one didn't know the finding, and then they compared it. So the time taken is very less, and you can really plan your flap well. So I think we do CT routinely for all cases.
Yeah. So now everybody does CT, and it gives a very good anatomy, what we need to do, and reduces the surgical time and fatigue, what we have to endure. We'll skip this slide. And this is a lady who had a large phylloids, which is malignant, which occupied about 40% of the whole, more than 40%. And Manish, when you have phylloids like this, what is the margin you need to use, and is mastectomy an option in such patients? Whether you could spare a nipple areola in such patients?
For the phylloids, we need a very good margin because of the high chances of the recurrence. So we should take at least 2 to 3 centimeter margin in phylloids. For most of the cases like this, they turn for the simple mastectomy. But for if we want to go for the oncoplastic, then we can consider for the superior. We can go for the inverted T with I think inverted T incision and we can.
This was a large tumor.
Yeah,
The extent of excision was that much, and we
then in that case, the only thing is it's LD flap or some volume replacement.
Yeah.
Flap.
So the nipple area was spared because the nipple area was about 5 centimeters from the tumor, and a margin of about 5 centimeter was what they excised, and this was the plan. And diaphragm was planned, and reconstruction was done in this manner.
At this point of time, it's important to emphasize that you need to excise the overlying skin as well, because
Exactly.
It's a compartmental excision.
Yeah, it's a compartmental excision. The skin has to go. If it is close to the tumor, the skin also has to go, and reconstruction. So
last few minutes, Dr.
Yeah, give me a couple of slides are there. One is bilateral and risk reduction surgeries. I will finish. So bilateral mastectomies are offered for bilateral cancers, risk reduction surgeries, and cancer on one side and BRCA positive on the opposite side. These are the main indications. What would you do, Hari, if it is a nulliparous patient and multiparous patient? Does your reconstruction differ in such patients, or you would do the same thing?
Yeah, if it is BRCA positive, basically we only do we avoid the breast surgery till she completes a family. Okay. So that's the first policy. And the salpingo-oophorectomy is we normally combine with the bilateral reconstruction. So basically the youngest patient we have done just a month back, and she was strongly BRCA positive with a family history, strong family history. Grandmother, mother, and one cousin all died because of breast cancer. So we have done at 24 years of age, nulliparous, unmarried actually.
So did you did you do an autologous reconstruction?
Autologous, yes, bilateral DF flap we have done.
So since these patients don't receive radiation,
no need for radiation. Yes.
Do you consider implant-based reconstruction much similar?
You can, but because they are young and the volume replacement is much better with DF flaps, so it is it gives a very natural appearance. And once you do a nipple areola reconstruction subsequently, then the overall long-term outcome is much better.
So this patient was married but had no children. We went and started doing nipple sparing, and what happened is nipple didn't have good blood supply, so we had to convert it into skin sparing mastectomy with LD with an implant. This is the donor side because she didn't want abdomen to be touched. She wanted children, and this is the post-op results. Gives good result because you are doing bilaterally. The symmetry can be achieved very well. And this slide shared by Dr. Raghu, similar case, but done with a diaphragm. So as I said, you can get very good symmetry with when you're doing bilateral because the control is with you. Hari, this is your series, I think. Sorry, I cannot do one by one. So it's complex surgeries, when you do complex flaps, can you combine lymph nodes with diaphragm?
Yeah.
And
so
when would you do?
Yeah, this is a lady, actually her main complaint was she had this a delayed reconstruction. So she had the lymphedema on the involved side. So you can show the pre-op.
I think I have to.
Sorry. Yeah, the behind is a pre-op. So this is a combination of a DF flap, and we can combine taking the opposite or ipsilateral, depending on the side of DF we are taking, we can take the groin lymph nodes. So we do we do ICG scan both for the lymphedema side as well as we do a reverse mapping just like we do for sentinel node. So we inject the dye along the flap so that we don't take any lymph nodes for the lower extremity, and that's a lymphovenous anastomosis which we have done in the limb, upper limb, and combined with in this case she had a big cesarean section scar. So because of a cesarean section scar, you cannot take groin nodes. The SIA is not was also injured. So that is why we did a LVA. In this case, the latest concept is to combine, do a omental free flap. So because already we have opened for DF, so the DF goes for the breast, and the same sitting you can get a mini omental flap as a free flap for lymph nodes and plug it into the axilla to the lat dorsi pedicle. So you do the DF for the intercostal pedicle.
So this we discussed BRCA risk reduction surgeries. This is the lady whom sometimes if they don't have enough tummy, you can do implant-based reconstruction risk reduction surgeries because no radiation. You can preserve the fascia of the serratus anterior and subpectoral flap can be done, and you can cover the fascia over the implant like that. And these are the post-op pictures. Little scarring there because of that, there is a wrinkling, but you can secondarily correct that. Lastly, this is old lady, 79-year-old, bilateral breast, and she wants reconstruction. What would you offer?
Yes, it is.
So we went and she was very adamant. We did bilateral mastectomy with implant-based reconstruction. We did something called a dermal sling, which you can use the lower flaps to cover that, but that was not sufficient. So we had to go and do an ADM as well. And this is the post-op result. So age is not a factor when you do reconstruction. We should be able to offer simpler procedure for even elderly. So there is a small newer technique, prepectoral, where they completely enclose this implant with ADM and put it in the prepectoral plane. And these are the complication rates when you put it in subpectoral, which is causes 43% infection, complications. When you put it in prepectoral, 50%. They still don't have long-term results of radiation and capsular contracture. So implant-based reconstruction as plastic surgeons would be our second option as compared to an autologous reconstruction. We'll skip this. This is the second.
Last slide.
Yeah, last slide. I'm going to the last slide. Sometimes we see these kind of reconstructions, defects. Only salvage procedures needs to be done, whether it is local flaps or free flaps, it doesn't matter. To conclude, we need to increase the awareness of reconstruction among the patients. Coordination and joint planning between the oncosurgeons and plastic surgeons are very important to achieve a common goal of giving very good aesthetic results, which increases the acceptance of these reconstruction among the general public. A team is very necessary. A single man cannot do these kind of complex reconstructions, especially the autologous reconstruction. And ultimately, patients should be the king, and they should be made to make the decision depending upon what we feed them information. And good to have pictures and to explain to the patients and have more than one solution for the same problem so that you can pick and choose the best one possible. I would like to thank all the panelists, Dr. Hari, Raghuveer, Dushyant and Jaiswal. They shared some of their work with me to present here. A special thanks to them. And also thanks to all the organizers for giving me this opportunity and conducting this GBM, which I've been attending all these years, even in the face of this rampaging pandemic. Thank you very much. If we have time, we could take questions. If there is no, then it's okay.
We will have the questions on the chat, and maybe we will just sort out the questions, and maybe you could join us tomorrow if
sure.
there are any. Yeah. So it's already 8:45 and dinner time. And on behalf of the HCG Cancer Center and the ABSI, I thank all of you for having spared so much of your valuable time. Especially the ABSI President, Dr. Somsekhar, has consented to be co-sponsor with this conference. So it's very, I'm grateful to Dr. Somsekhar. I'm also thankful to the chairpersons today, Dr. Pankaj Shah, Dr. S.S. Alurkar, and Dr. Shakuntala Ben Shah, who agreed to be the chairpersons for various sessions. I also thank the moderators, Dr. Prasad Narayan, Dr. Vani Parmar, Dr. Shalaka Joshi, Dr. Vamsi Krishna, and Dr. B.C. Ashok, who agreed to moderate these very, very interesting and interactive panel discussions. I thank all the panelists who are with us. I believe that there were up to 500 online people following us on the live link that was sent. And at any given time, as you can see, there were at least 40 people on the chat. I also thank the industry, which very generously extended help in organizing this conference. And the entire credit for this year's GBM 2020 goes to the two dynamic organizing